Welcome to PEFRI's 17th Annual Postgraduate Course entitled Code White. This event was organized by the following individuals: Dr. Julius Dalupa, Dr. Tim S. Trinidad, Dr. Jude Guiam, and Dr. Maria Cristina Marañon. We hope that you'll enjoy the 4-day webinar series we've prepared for you and get a chance to win exciting prizes on the last day. Let's start learning. Let's enjoy and start the program. May I now call on the virtual floor our moderator for the first two sessions, Dr. Maribeth Santos and Dr. Maria Cristina Marañon.
Okay. Good morning, everyone, and welcome to the second day of Code White.
We hope you and your loved ones are safe and dry.
We are hoping that everything will go smoothly today despite the connectivity issues that the whole island of Luzon is experiencing.
Let's kick off our Saturday morning with positive vibes and learning.
Our first speaker is an alumni of the Faculty of Medicine and Surgery and of the different residency and fellowship training programs of the Department of Internal Medicine of UST. Possessing true Thomasian tiger power, she is the current chair of the Department of Internal Medicine of the Faculty of Medicine and Surgery of UST and is the current chair of the Department of Medical Education and Research of the UST Hospital.
She was awarded as the most distinguished academician of our society last year, which reflects her immense passion for teaching. Ladies and gentlemen, I give you one of our best educators, the original title holder of Beauty and Brains, the fierce tigress, Dr. Maria Piedad Rosales Natividad.
Hi, everybody. Thank you, Tina. Thank you, Mbeth. So this morning, I am supposed to is my slide on screen now?
Yes po, Doktora. But
so this is my
Doktora, may ano lang po, may shadows po sa screen. Maybe the chat box po siguro should be closed.
Okay, 1 second. Let me get rid of the chat box.
Okay, Doktora, it's clear po. Thank you.
It's okay, na?
Apo.
All right. So this morning, I'm going to be telling you about the chest radiograph and how to interpret shadows. This is going to be a roughly 30-minute, 40-minute lecture. So if there are any questions from the group, just please put them in the chat box, or you can say it out loud during our question and answer portion later. So this is the outline of my lecture for today. We're going to be discussing a little bit about technical acceptability of the X-ray. It is very important because before you can interpret a chest X-ray properly, you have to know if it is technically acceptable. We will also touch on interpretation using ATMLL, and this is how we teach our medical students. Are there many lung lesions? And then finally, we will touch, because it is the COVID pandemic, we will touch on the role of the chest X-ray during these COVID times. So first is the technical acceptability of the film. And I put here 4 P's that you're supposed to look at: position, penetration. You look at whether the X-ray has the full picture and whether the patient is on full inspiration. So let's touch on position first. Very important that if you look at the chest X-ray, you look at the position of the patient when the chest X-ray was taken. This particular X-ray was taken in the PA view. And how do we know this? That label is supposed to be in the left upper hand corner. So if there is a label in the left upper hand corner and it is oriented in that manner, then you know that the patient had the chest X-ray taken in the PA view. And this way you will be able to estimate the size of the heart, as well as you can look at the other chambers of the heart and the rest of the lung fields. Now, it is also important that you take note of this because this is in an X-ray in the PA view. And this is the same patient with an X-ray done in an AP view. So meaning the camera was in front of the patient and the film was behind the patient. And you can see here that the heart looks enlarged. So you may mistakenly diagnose the patient as having a cardiomegaly when all the time it was just because of the position of the patient. So again, very first thing you have to take note of was the patient's X-ray done in a PA view, so teleradiography. So there are requirements for that. Next is, you have to know if the patient was centered and not rotated. Parang Miss Universe, may quarter turn to the right or left. If the patient was centered when the chest X-ray was taken. So if you take a look at this X-ray and you glance at it, how do you know if the patient was centered or whether or not there was slight rotation when the chest X-ray was taken? You focus on this particular part of the chest X-ray. So you can see here that you look at the spinous processes of the vertebra and you look at the distance from the clavicles on either side to the spinous process of the vertebra. And if they are equidistant, it means that the patient was centered and not rotated. So I will show you another X-ray, and this I would like you to answer me. Is the patient in this film positioned properly? Tina, you have a poll that we can show them.
Yes po,
So
Doktora.
please answer. I will give you just 10 seconds. Okay, 10
Okay,
seconds.
Doktora, majority of them answered no.
No, so 57% versus 43%. So let's take a look at the chest film and see whether or not the patient is positioned properly. Again, you take a look at the area where the clavicles are. There you go. And you can see that the spinous process in this X-ray is much closer to the right clavicle. So this patient was rotated a little bit. And when you see that, you will have to look at the heart, particularly the heart, as well as the hemithoraces, because they may not seem equal. So if a patient is rotated, it may mistakenly show enlargement of some of the chambers of the heart. So that is our first requirement. Look at the position of the patient. Next is penetration. So what is that? Penetration means the blackness or the whiteness of the chest X-ray film. This is a well-penetrated film. You can see the vertebral bodies behind the heart. And you should be able to see that because you will be able to diagnose also any lesions that could be behind the heart. So if it is too penetrated, it is over-penetrated, the X-ray becomes very black. But if it's under-penetrated, the X-ray seems whiter than normal. So this is an under-penetrated film. You can see that there seems to be haziness. Tina, can you see my pointer? On
Yes
the
po.
screen. Yes, okay. So there seems to be some haziness in both lower lung fields, but you take a look at the area behind the heart, you can hardly see the vertebral body. So this is an under-penetrated film. This, on the other hand, is an over-penetrated film. When I show this to my students, I tell them you can almost see the bone marrow. No? So it's so over-penetrated, you can hardly see any bronchovascular markings. So what is the importance of this? It becomes very important now when, especially if you are comparing serial films. So if you take a look at this first X-ray, this is a well-penetrated film. And then the X-ray was repeated and now it is under-penetrated. And you can take a look at the lower lung fields. It seems like the patient has developed suddenly a pleural effusion, but it is all due to the under-penetration of the chest X-ray. So you have to be very, very attentive to the technical quality of the film. This, on the other hand, is a patient with a well-penetrated X-ray, and you can see that there are infiltrates on both of the lung bases. Unfortunately, when the X-ray was repeated, it became now over-penetrated. So if you take a look at the lower lung fields, it looks like the infiltrates have disappeared. So this is not because you're a very good physician and you cured the patient immediately. This is just because there is a problem with the penetration of the film. So position, number 2 is penetration. Let's take a look at the other two. The patient's X-ray should have the full picture and the patient should be in full inspiration or total lung capacity. So those of you, I'm sure all of us in attendance now have had chest x-rays taken. You remember what the technician says? Take a deep breath, hold it, and that's the time that they take the film. So the patient should be on full inspiration. This chest x-ray definitely is not acceptable. You do not see the bottom part of the lungs. They have cut away the claustrophonic sulci, and the claustrophonic sulci are a vital part of a complete x-ray interpretation. This, on the other hand, was not taken on full inspiration, and I'll teach you in a bit how to determine if it's on full inspiration or not. And if you take a look at the bottom part of this chest x-ray, it looks like there are bibasal infiltrates on both, it's bibasal, so it's on both hemithoraces. And if you have a chest x-ray done during this COVID era, this will immediately be tagged as a COVID suspect, no, COVID pneumonia. But all the patient had to do was take a deep breath to total lung capacity, and you see that those infiltrates that seem to be there initially have totally disappeared. And this is because the diaphragm has gone down, the lungs in that area in the bases have been able to expand, and so those infiltrates have now disappeared. So you have to have the full picture, and the patient should be on full inspiration. So when you look at the technical acceptability of the film, it's just like when you submit a photo for an interview for passport. No, if you submit a photo that is too over penetrated, definitely it will not be accepted. If you submit a photo that is under penetrated, again, this will be declined. And syempre, boom, biglang ganun, no? In your face. So you should not accept, you should not submit a photo like that, but you should submit a photo that is gorgeous and beautiful and complete. Okay, so that is how you should look at the chest x-rays. You have to look at the technical aspect first before you are able to interpret. So now let's interpret. And this is how we do it in med school in UST. Are there many lung lesions? And this stands for the abdomen. It's actually the thoracic abdominal interface, the thoracic cage, the midline structures or the mediastinum, and then one lung, and you compare to the other lung, and then you compare both lungs at the same time. And we do it in this manner so that it will be systematic and organized, so that there is less risk of you missing out on anything that is important in the chest x-ray. So let's look first at abdomen. There are four things that you have to look at. The first is the level of the hemidiaphragm, and we usually talk about the right hemidiaphragm. At total lung capacity, the right hemidiaphragm normally is at the level of the 10th rib or the 10th intercostal space. You also compare the right and the left hemidiaphragms. The right hemidiaphragm is usually or generally higher than the left by 1 intercostal space. You look at the contour. What is the contour of the hemidiaphragm? It is dome-shaped. So you have to figure out, is it really dome-shaped? Is it dome-shaped enough? Because flattening of the hemidiaphragms, flattening of that usual dome-shaped contour could also mean something that is pathologic. And finally, you look at those claustrophonic sulci. That's why it's very important that the x-ray should have the full picture. Okay, so first, this is our second question. You look at the right hemidiaphragm. So that is the right hemidiaphragm. So can you figure out what is the level of that right hemidiaphragm? Tina, our poll. It's not actually a poll. It's a multiple choice question. Okay, so you look at, I will give you 20 seconds so that you will be able to count. Okay, it's like looking at the stock market. Okay. Okay, so, okay, let's end the poll. So 38% said 10th rib, 33% said 9th rib, and then the rest, 8th and 7th. Okay, let's take a look. When you're going to look at, or when you're going to count for the level of the right hemidiaphragm, again, this is the right hemidiaphragm, and we usually use this to count. You always look for that first rib. This is that first rib, the one that goes downwards and forward. So these are the ribs viewed from posterior. When they're horizontal like this is the posterior aspect of the rib. And when they go down like this in front, Oblique, this is the anterior aspect of the rib. So you take a look, or you look for that first rib. So if this is rib number 1, the one right beside it there is rib number 2, and then rib number 3. So I will draw it out for you so that it's easier for you to take a look. That's rib number 1, 2, 3, 4, and then you go count downwards. So in this particular X-ray, that hemidiaphragm is at the level of the 10th rib. Okay, so I will go through that again so that you will be able to visualize. So that is the first rib. So that is the second, third, and fourth, and then you count downward from there. So the right hemidiaphragm is at the level of the 10th rib. So you practice, you get X-rays later, then you take a look. How you look for that first rib first, and then you count downward from there. Second thing we have to look at, the right hemidiaphragm is usually higher than the left by 1 intercostal space. That is in general. So this is the right hemidiaphragm. It is higher than the left by 1 intercostal space. Next is we look at the contour. The diaphragm is supposed to be dome-shaped. How do we know if it's dome-shaped enough? If you just take a glance at this X-ray, it looks like the hemidiaphragms are dome-shaped. But if you want to be really accurate about it, you draw a line like this one from the claustrophonic to the cardiophrenic sulcus. And then you draw a line perpendicular to that first line at the highest level of the hemidiaphragm, and then you measure line B. Line B should measure 1.5 centimeters or more. And if it measures 1.5 centimeters or more, it means that your diaphragm is really dome-shaped. What is the clinical importance of this? If the diaphragm becomes flatter, it usually indicates that there is more air in the lung that is pushing down on the hemidiaphragm. So if there's flattening of the hemidiaphragm, this usually points to hyperinflation. And then next, you look at the claustrophonic sulci. What are those? Those are those things in the side of the chest X-ray, and the claustrophonic sulci should be sharp. Okay, I'll show you some films later that will reveal that sometimes there could be blunting of the claustrophonic sulci, and I will tell you later what the clinical significance is. Okay, what is the level of that right hemidiaphragm? Maybe you can put it in the chat box. Come on, everybody, I want you to figure out what is the level of that right hemidiaphragm. Okay, chat box, chat box, chat box. 9. Okay, so meron 9. Okay, ano pa? Is that it? Is that your final answer? Okay. Most of you are saying 9. So let us take a look. If that is the first rib going there, this is the second rib. If that is number 2, that's number 3. 4, 5, 6, 7, 8, 9. Oopsie! It's at the level of the 10th. Okay, so again, you look for that first rib. That is the first rib. It goes down like this. If this is the first rib and this is the second rib, you trace it all the way there. So that's rib number 2, 3, 4, 5, 6, 7, 8, 9, 10. So this is at the level of the 10th rib. It's very confusing sometimes because the first, second ribs are always, you know, they're always magkatabi in the top or in the apex of the lung. So you have to be very careful when you're taking a look at the first and the second rib. Okay, next, look at the right hemidiaphragm. Is it higher than the left? Yes, it is still higher than the left. Is it higher by 1 intercostal space? Yeah. Okay, and then look and see if it is dome-shaped. So how do we know if it is dome-shaped? Draw a line from the claustrophonic to the cardiophrenic sulcus. Draw a line perpendicular to that first line, and you measure it, and it should measure 1.5 centimeters or more. Okay, and then finally, you take a look at the claustrophonic sulci. The left claustrophonic sulcus is sharp, but that right claustrophonic sulcus is blunted. So you can see that it doesn't have that acute angle. So what does it mean if there is blunting of the claustrophonic sulcus? It could mean one of two things. Number one, there could be effusion or fluid in the pleural space. Or number two, the pleura in that area is just thickened. So there's pleural thickening or pleural fibrosis. If you want to be sure, then I will show you later now in another chest X-ray where you make the patient lie on his side and what to expect. Very good. Level of the right hemidiaphragm here. So here, obviously, you can see that it doesn't look like your usual X-ray. And if you count the level of the right hemidiaphragm, guys, count very quickly. What is the level of the right hemidiaphragm here? No one wants to venture an answer? If, okay. Kala ko answer si Maribeth pala, 11 or 12. 11. Okay, so let us see. Again, magkakatabi, no? Kainis eh. They're all crowded there. If this is the first rib, that is the second rib, 2, 3, 4, 5. So let me count it out for you. 1, 2, they're magkatabi, they're nakasiksik. 3, and then so on down. So the right hemidiaphragm here is beyond the 12th rib. So what does that mean again? At total lung capacity, that right hemidiaphragm should be at the level of the 10th rib. So if it is below that, or it's a low set hemidiaphragm, it means that there's hyperinflation. And this is what you usually see in patients with emphysema. You take a look at this, that chest seems like it is more expanded than usual. You take a look at the right hemidiaphragm, is it higher than the left? Not really. They're at the same level. But what is more significant here is you look at the contour. You don't even have to measure anymore claustrophonic to cardiophrenic. It looks almost flat. So a low set hemidiaphragm and a flattened hemidiaphragm, these will point to hyperinflation. And this is what you see in patients with emphysema. You may also see this in patients with acute exacerbations, acute severe exacerbations of asthma. But usually in asthma, when the exacerbation is done, when the patient goes back to normal or near normal, the X-ray will also be less hyperinflated. Okay, so next is, or we're done with the abdomen, the 4 things you have to look at. Level of the right hemidiaphragm, compare the right and the left. You look at the contour of the hemidiaphragms, and then finally the claustrophonic sulci. Next, we go to T, thoracic cage. And what do you look at here? You look at the ribs and the intercostal spaces. They should be pantay or symmetrical. If there is narrowing of an intercostal space, this is usually due to one of 2 things. Either there is volume loss in the lung, so this is what we call as atelectasis, or the pleura is so thick that it is trapping the lung. So this is what we call a trapped lung or fibrothorax. What can widen the intercostal space is anything that has volume. So whether the volume is in the pleural space, so this is what you see in a pneumothorax where there is air in the pleural space, or pleural effusion where there is fluid in the pleural space, or the volume is inside the lung itself, like what we saw in our most recent X-ray when there is emphysema. Okay, so you have to compare one side to the other side. So when you take a look at the intercostal spaces and the ribs, they have to be symmetrical. Now, I use this with my medical students. If you observe very closely, the ribs and intercostal spaces here do not seem to be symmetrical when compared to the right side. But if you take a look at the position of the patient, how do you know again? The spinous process and the distance to the clavicles on either side, the patient is a little bit rotated. So this might explain the asymmetry of the intercostal spaces, because I don't see anything in the lung itself that may contribute to the asymmetry of the intercostal spaces. I'll show you some examples. So definitely this is narrowed intercostal spaces. And because of the narrowing here, because of a fibrothorax, you can see that the pleura is very thick. This is a trapped lung. So this lung cannot expand. There are narrowed intercostal spaces. So the left lung has now widened the intercostal spaces because this is now a compensatory emphysema. Same thing on the other side. I cannot see my slide because the chat box is there. Okay, so there is narrowing of the intercostal spaces, this time on the left, and there's compensatory widening of the intercostal spaces on the right. So this is your compensatory emphysema. What is causing the narrowing of the intercostal spaces on the left? I think it is a combination of a fibrothorax. Look at that pleura, it's very thick, and maybe there is some form of volume loss also, or atelectasis. This and oops. So this is, I already showed this to you earlier. This is a patient with emphysema. So if there's more air inside the lung, the intercostal space is widened. The problem with this kind of X-ray is, it is usually easier to diagnose asymmetry if one side is pathologic and the other side is normal. In a patient with emphysema, both sides are pathologic. So how will we be able to diagnose widening of the intercostal spaces in patients with asymmetrical lung disease like emphysema? You have to know what normal is. So the pulmonologists in this group, especially the older ones, so Dr. Villaspin, he's seen a gazillion x-rays. So even myself, maybe just a million, okay? So we've seen a lot of x-rays that are normal. So immediately when we look at this, we know it's abnormal. So I would like you to be able to practice that. You'll take a look at normal x-rays. So when you take at first glance, you immediately know that this is widening of the intercostal spaces. I have another question. Where is the pathology here? Is it the right lung with the widened intercostal spaces? Or is it the left hemithorax with the narrowed intercostal spaces? Tina? Tina, there you go. So where is the pathology here? The right side seems to have widened intercostal spaces. The left side seems to have narrowed intercostal spaces. Okay, 5 more seconds. Uy, parang Biden-Trump lang to ah. Okay. Okay. Sige, so most of you said it is on the right side. That's correct. So the pathologic side here is the right side. So what do we see here on the right side? You can see that there is widening of the intercostal spaces, and you look at that. That is a visible, visceral, pleural line. And when you see something like this, with absence of bronchovascular markings peripheral to that, this is your pathognomonic radiographic sign of a pneumothorax. So again, pneumothorax is air in the pleural space, so it is volume containing, so there is widening of the intercostal spaces. Okay, so that is where the pathology is. Again, a visible visceral pleura, that is your sign that you have a pneumothorax. However, I think the next lecture is on ultrasound. I think the ultrasound is a more sensitive test. It will be able to diagnose a pneumothorax better. Next is M, everything in the middle, including the trachea, the heart, and the hyla. So take a look at this X-ray, that is the trachea, it is in the midline. The heart is in the midline also, although the left ventricle projects leftward. But how do you know that it is in its proper place? That apex should be along the midclavicular line. And then finally, you take a look at the hyla, the left and the right hilum. And in general, the left hilum is higher than the right. Now, what is important here when you look at the hilum is you look at that size, particularly of the right descending pulmonary artery. You look at the size, because if this were an actual film and I put my thumb over that right descending pulmonary artery, it should be able to cover the whole RDPA. If I can see the right descending pulmonary artery, which is bigger than my thumb, then this is something that is pathologic. Take a look at this film. The trachea is in the midline. The heart is still in the midline, but if you take a look at the apex, it is along the anterior axillary line. So if there's displacement of the apex, it could be a primary cardiac pathology like what we have in this film, or later on, I'll show you instances where a lung pathology is the one that is displacing the apex B. In this particular film, I'd like to stress aside from the displacement of the apex B, to take a look at that giant right descending pulmonary artery. So again, if the patient has something like this and you put your thumb over the actual film and it's bigger than your thumb, then this is what you call a thumb sign. And this represents pulmonary arterial hypertension. Another thing that you can take a look at also is that cardiac waistline. That heart is supposed to have a waistline. Now, if that waistline is obliterated, like in this film, you have bulging in that area, this could mean either it's a big left atrium or that main pulmonary arterial trunk is also dilated. So for this particular film, since you already have the thumb sign there, then you have to suspect that the main pulmonary arterial trunk is also dilated. So again, this points to pulmonary arterial hypertension. Now let's take a look at some lung pathologies that will displace the midline structures. So volume containing pleural effusion and pneumothorax will push, but volume loss like atelectasis will pull. Okay, so this, we took a look at this already. This is a pneumothorax on the right. So what happened here? Look at that trachea and the heart, they have been pushed, contralateral deviation. So if you have volume containing pathologies, they will push. Okay, this one is a pleural effusion. That is your classic meniscus sign. So if you have a sign like this with a homogeneous opacity with a curved upper border, that is pathognomonic of a pleural effusion. So pleural effusion again is volume containing. So it is going to push. So if you take a look at the trachea and the heart itself, it is pushed contralaterally. So this is a pleural effusion. Okay, this one, can you see the trachea here? The trachea is deviated towards the side of the pathology. And you look at the right border of the heart, you don't even see the right cardiac border. And if you look closely in this area, this is actually part of the right lung that has herniated to the left. And since the pathology is on the left and the midline structures have been pulled, then this is volume loss. This patient has an atelectasis. Okay, and then finally the LL, lung lesions. Look for infiltrates on each lung, and then you compare one lung to the other lung. So you look for it in this manner. So you sweep downwards, you look at the other X-ray, the other lung, you sweep downwards, and then you compare one side to the other side. So I'm just going to show you some X-rays with findings in the lung. So again, sweep first, the right lung here, normal, 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 and then the left lung, normal, normal. Oops, there seems to be something here in the left lower lung field, hazy infiltrate. So immediately you know that the patient has a pathology in the left lower lung field, and it's probably a pneumonia. If you see something like this during this era, immediately your patient is a COVID suspect. I just want to show you this because we're famous for this the world over. We export this to many countries in the world. If you see any cavity here in the Philippines, okay, cavity, especially if it's in the upper lung, immediately you think about what we're world famous for. This is, you have to rule out tuberculosis. Now, if this patient were from another country, you think of other things, but if it's a Filipino, then you think about tuberculosis. If you see things like this is cannonball metastasis. So I'll just go very briefly to some of the interesting findings that you may have in the X-ray. This is a patient with a consolidation in the right lower lobe. How do I know it's in the right lower lobe? Because I can see that right cardiac border. I'll show you later another X-ray which will be able to help you locate whether or not the findings are in the anterior or in the right middle lobe or in the right lower lobe. So this is a patient with consolidation. You can see that there are black tubular structures within that density. So this is what you call your air bronchogram. And finally, this X-ray, you have here, this is what we call an S sign of Golden. When you see an X-ray like this, it means that there is obstruction to the right upper lobe bronchus, causing now atelectasis of the right upper lobe. This was supposed to have been the horizontal fissure. But because of the atelectasis, it is now pulled upwards. So you think about something that is obstructing that right upper lobe bronchus. So you have to immediately rule out the presence of a mass obstructing the right upper lobe bronchus. We already had this earlier. This is a patient with a homogeneous density with a curved upper border. And you can see that there's slight deviation of the heart to the right side. This is a patient with a pleural effusion. Now, if you want to be sure and you don't have an ultrasound, what you can do is you let the patient lie on the lateral decubitus, and you can see now that the fluid has gravitated. This is what we call layering. So what does layering tell you? If you measure from the inside of the chest wall, up to the highest level of the fluid. And if you have more than 10 millimeters or 1 centimeter, then it tells you have enough fluid to do, at the very least, a diagnostics or a synthesis. But because ultrasound is found in so many different institutions now, you can just use your ultrasound. It becomes much simpler. Now, this particular film, what do you see? Or rather, what don't you see? You can see that the right lung has many of these bronchovascular markings, and you don't have any of those bronchovascular markings on the left lung. So if you see this, this is an area of oligemia. This represents a pulmonary embolism. You don't have perfusion anymore in the left lung, and this is what you call the Westermarck sign. This is another sign of pulmonary embolism. This is the Hampton Sump. It is a triangular density with the apex pointing towards the hilum. So what does this tell you? It means that the perfusion to this part of the lung has stopped. And because there is no more perfusion, that lung has actually started to infarct. So this is a pulmonary infarction. And this is what you can see in some patients with a pulmonary embolism. Now, this is another question I have for you. You can see here that there's a lesion here in the left upper lung field. So my question for you is this a pleural-based mass, or this is a lung mass or parenchymal mass? Tina, can you put in the poll? Is this pleural-based, or is it found in the lung parenchyma itself? Okay, so most of you, 80%, are saying it's a pleural-based mass. So let's take a look. Let's see how to determine that. So how do you know if it's pleural-based versus parenchymal? You take a look at the angle that the mass or the lesion makes with the chest wall. So you can see here that the angle is obtuse. If the angle is obtuse, then this is probably in the pleura. Compare it to this, where the angle with the mediastinum is acute. So you can see here that the angle is acute. If you see something like this, then this is a parenchymal lesion. So just to illustrate it even further, the angle is obtuse. And if you look at the CT scan, you can see that this is in the pleura. It is actually a loculated pleural effusion. But if the angle is acute, then this is a lung or a parenchymal mass. So these are just some of the tips that I would like you to remember. And then just to stress that it is very important to do it systematically or in an organized manner. If you just take a look at the lung itself, you might miss out on these. This patient has multiple fractures. And so it is very important that you include the thoracic cage in your assessment. Now, a little bit about the lateral view. Is it important? Yes. If you ask the pulmonologist, they will always request for PA, which is our first film, and a lateral view. So what does a lateral view tell us? First, you have to look at the anteroposterior diameter. So if you remember that X-ray that I showed you earlier, that patient with emphysema, if you get a lateral view, it will have a very much bigger AP diameter. So normally, the AP diameter of the patient is less than the lateral diameter. But in a patient with a barrel chest, that AP diameter increases. Aside from that, though, it could help us also distinguish problems with some of the chambers of the heart. So you can see here that behind the sternum, the heart should be abutting just the lower third of that sternum. So these are the things that you look at. And then you also have to look at the retrocardiac space. That retrocardiac space should be able to contain one vertebral body. So if you have obliteration of the retrosternal space, this will point to right ventricular hypertrophy. If you have obliteration of the retrocardiac space, this may point to either a left atrial enlargement or a left ventricular hypertrophy. Another thing also you have to look at in the chest X-ray lateral view is the posterior gutter. The posterior gutter goes much deeper than what you would see on a PA view. So take a look at this. On a PA view, the Claustrophonic Sulci are sharp. But if you take a look at the lateral view, you can see that there is fluid in the posterior gutter. And this will explain why it comes out like that. So what is the clinical significance of this? It's not exactly very clinically significant, but it will complete your X-ray interpretation. And then here, I told you earlier that you can also locate where a pathology is, whether it is in the right middle lobe or in the right lower lobe, because of the silhouette sign. So you can see here that you do not see that right cardiac border. This means that this consolidation is in the same plane as the heart. The heart is found anteriorly. Okay, so this is the consolidation that you see here. It is on top of the heart. And so you know that the consolidation is in the right middle lobe. Okay, so you do not see that right cardiac border. So that is a positive silhouette sign. Now let us take a look at the x-rays in the time of COVID. So this is my final question for you. What is the diagnostic or pathognomonic x-ray finding in COVID? So Tina? We're winding down already, so just give me a few minutes. I'm gonna go a few minutes over time here. So what is a diagnostic x-ray finding in COVID? So you have choices here: consolidation, ground glass appearance, rounded opacities, or is it a pleural effusion? 5 more seconds. So most of you are saying it is. Okay, Tina, let's stop the poll. Ground glass opacities. Okay, very good. Problem is, there really is no diagnostic finding of the x-ray in COVID. So this came out from the UCLA School of Medicine. And you can see here that if there are multifocal peripheral consolidations, multifocal rounded opacities and nodules, then these are typical, in quotation marks, for COVID. There there really is no one presenting manifestation. So you can see here, again, it is usually bilateral. You have rounded nodular infiltrates. And then the more widespread it is, the more severe the pneumonia is. This is from the BMJ, it came out in July. So what do you need to know about the x-ray? There's no single feature, but if you have multifocal peripheral lung changes, ground glass opacity and or consolidation, then you will have to suspect that the patient may have COVID. So what is important though is to try to look at the serial film. So initially, this is a chest x-ray, and you can see these x-rays are 1 day apart, and you can see that there's progression now. So the x-ray may not help you diagnose, but it may help you prognosticate in terms of the severity of the infection. So again, what is important here is it may still be normal in up to 63%, but the changes that are most common are ground glass, horizontal linear opacities, consolidation, usually bilateral, and usually initially in the lower zones. So this is what I meant by trying to assess for the severity. This came from Emergency Radiology Journal. The chest x-ray A is normal. Chest x-ray B, it is grade 1 because there are opacities less than 1/3 of the lung. Grade 2 is C, alveolar opacities 1/3 to 2/3 of the lung. And then grade 3 is more than 2/3 of the lung. If you have a grade 3 x-ray, then this is already your acute respiratory distress syndrome, then it adds to the morbidity of the patient. So this is a statement from the American College of Radiology. The x-ray or the CT scan cannot accurately diagnose COVID-19 and separate it from the other respiratory infections. And you also have to remember that all of these findings are not specific. And are not confirmatory for COVID. It is still your RT-PCR. That will be the confirmatory test. And also, a lot of patients have normal x-rays. So what did we do this morning? We looked at the technical acceptability of the film, the PPPs, the interpretation, and a bit on chest x-ray in COVID. Remember, position, penetration, the full picture, and full inspiration. Use are there many lung lesions to try to make it a more systematic and organized means to interpret your x-ray. And then finally, for COVID-19, you may have normal x-rays. It is not diagnostic, but most common x-ray findings that are found bilateral, multifocal, peripheral infiltrates, and the ground glass appearance. So that is all you need to know about the chest x-ray and how to interpret shadows. Thank you very much for your attention.
Thank you very much po, Dr. Natividad, for that very wonderful presentation. Doctora, we have one question po.
Yes.
So what are the challenges that you have encountered in interpreting chest radiographs during this pandemic?
It's very challenging. Okay, that's the first thing. It's very challenging because every patient who has findings in their chest X-ray is immediately a COVID suspect. Now, if the patient has serial films and they're available, it's best that you try to compare them, because if, for example, there are patients who have chronic findings on their chest film. So chest X-ray done 2 years ago, for example, shows infiltrates in the right lower lung field. Last year, same finding. 6 months ago, same finding. And then recently, same finding. And the patient has no symptoms whatsoever. Then most probably you will say that these are chronic lung changes and the patient is not a COVID probable or a COVID suspect patient. But you're never sure. So that is the biggest challenge, I think, since they're non-specific findings. A lot of it you'll have to correlate clinically, but one can never be sure about X-ray in terms of diagnosis of COVID-19. That's the most significant challenge.
Yes, thank you very much, Dr. Apici, for that answer. I do agree, no? Clinical correlation pa rin po. You have to have a good clinical eye also. So we would like to thank Dr. Apici for delivering this very, very, very comprehensive lecture. And we would like to present this certificate of appreciation to Dr. Natividad for having lectured in the 17th PEFRI postgraduate course signed by the organizing committee. Thank you very much po, Dr. Apici.
Thank you. Thank you.
So we will now move on with our next speaker. So our next speaker graduated and trained at UST and completed her postdoctoral fellowship training for pulmonary hypertension at the Massachusetts General Hospital. She is a member of the Asia Venous Thrombosis Forum and is a member of the Pulmonary Hypertension Association. Her other passion is ultrasound, and she is currently a member of the Society of Ultrasound, Medical Education, and International Consensus Conference on Ultrasound in Medical Education.
Also passionate about teaching, she completed her Masteral in Health Professions Education at UST and teaches physiology at the same institution. She is the head of the medical ICU at UST and the head of pulmonary vascular units of both UST and Cardinal Santos Medical Center. She is likewise affiliated with the Los Santos Medical Center and San Martin de Porres Medical Center. Dear colleagues, there's no other person more suitable to teach us about ultrasound than Dr. Julie Christie Visperas.
All right. Good morning, everyone. Thank you, Tina and Maribeth, for your generous introduction and very kind. All right. So stop screening, share screen from or your end, I think, so that I can share my screen. Okay, so I'm sharing my screen now. Can you see my screen now?
Yes po, Dr. Julie. Thank you po.
Okay. Okay. All right. So, okay, I'm tasked by our organizing chair, Dr. Maranyon, to talk on the utilizing bedside ultrasound to diagnose non-COVID pulmonary diseases. Even if it is entitled non-COVID pulmonary diseases, I will still show you some ultrasound clips of COVID, no? But of course, we will tackle first the basics, no? So the outcomes for this learning for the learning for this morning is to give an overview of the basics of pulmonary ultrasound. I do know that not all of us have had in-depth training on ultrasound when we were in med school, no? And of course, the use of bedside ultrasound have been around for a few years already, and we tried to do our medical education, no, add-on from the time, or even if we were not able to do this in our med school. But of course, some of our younger colleagues who are part of our postgrad right now who are listening, okay, have had some training, I'm sure. Now, we also utilize the basic terminologies in interpretation of the lung ultrasound, and of course, highlight the indications, correlation of ultrasound findings to the clinical presentation of a non-COVID pulmonary patient. Okay, so the roadmap will be, first we will tackle the normal lung ultrasound findings, but in the process, we will also try to see some of the important knobs or knobology and the ultrasound settings that you have to know so that you will be able to set up your ultrasound. And of course, the scanning pane as to what area you will have to deal with, to be able to see more on the ultrasound, and of course, some of the application to our clinical cases. So Dr. Lichtenstein is the father of ultrasound in pulmonary. So he is a French physician, pulmonologist, who was able to develop the 7 principles of lung ultrasound. He is a proponent of the Blue Protocol for ultrasound. So you have here a list of the basic technique, but what I am going to tell you is that the ultrasound is a 2-dimensional apparatus, and what you are able to see more are usually the interaction of air and water, okay, intimately mingled, and the lungs is the largest organ. The signs are from pleural line, so everything will come from a pleural line, and when the structures you are going to sample or see or scan will bounce, or the wave, ultrasound wave will bounce from the pleural line, then you will be able to see some artifacts, no? And then of course, the lung is a vital organ and most signs are dynamic. So everything should be in a, not in a still picture, but you need the real time. So that's why ultrasound is very good. And nearly all acute disorders of the thorax come in contact with the surface. What is important when you use ultrasound, so I actually have my ultrasound probe here, okay? The ultrasound, okay, should have a gel, no, on the surface. So it will be very important to have that gel, because if not, then you will not be able to see anything, because you need that interaction. So I have this handheld ultrasound here. All right. So next, the principle of air fluid ratio. You should understand that from air above and the fluid below here, okay, I'm sure you are seeing my pointer. The air will be more or less going to be seen above this graph is the pneumothorax, and then below it is the normal lung. And in between will be interaction from the pleural line, interstitial syndrome with the ground glass or thickened septa, pneumonia, which is a combination of consolidation findings as well as some B lines as well. And then of course, atelectasis and Plural Effusion, which is going to be visualizing fluid, which is anechoic. Okay, so the main disorders will be from a normal lung, and in between that will be a pure air and a pure fluid. No? So pure air is pneumothorax, pure fluid is pleural effusion. Okay. So in thoracic ultrasound, what we will be able to see mostly, which is important to us, is the chest wall, the pleura, and the lung. Okay, so clinically, what is going to be bedside it's significant for us is pleural effusion, empyema, hemothorax, and pneumothorax. No? And of course, for the pulmonary edema, in correlation with the patient's clinical picture. Okay. Also here we have consolidation, and of course, sometimes you could also see atelectasis in the setting of effusion. Now, aside from the thoracic ultrasound, we also have pulmonary vascular ultrasound. No? So we could also be able to see whether the patient has some obstruction in the veins, for example, the popliteal and the femoral vein, which are the proximal, will denote proximal DVT. And of course, the cardiac ultrasound, so that we will be able to interrogate whether the patient has some form of pulmonary embolism already, with the right ventricular increase in the dimension in the heart. Now, for knobology, just a quick run through. If this is the ultrasound, which is usually being used, no, in the war zone, no, very compact, just like a laptop, no, but it can withstand a lot of pressure, no? So you have, this is the screen, and you have the knobs here. It's important that you will be able to know what is the gain, okay? So that you'll be able to adjust, no, the ultrasound picture that you have in your screen. Of course, the width or the depth of the thing that you are focusing on, and as well as whether you need to put in some increase an increase or a decrease in the depth, okay? And of course, you'll be able to see also the preset, no, whether you are going to be at a linear probe, curvilinear probe, no. So this particular ultrasound, bedside ultrasound machine will be able to have different probes. But what I am holding right now has only one probe for all cardiac preset or even the abdominal preset, okay? So this one, okay, so this is the M mode, and then this is the Doppler, the color, and the 2D. So there are certain knobs that you have to note. Usually what we have, like in this two-dimensional video, it's two-dimensional, it's just black and white. But if there is some color, you can put in the Doppler or the color. M mode is for motion. So for example, for pneumothorax, later on that I will tell you. So there is a corresponding knob and the preset on the screen that you will be able to see. Okay, so now let's look at the air fluid ratio. So you have here, remember the schema that I told you about air and fluid. So when there is pneumothorax, okay, so the principle behind it is from the pleural line, okay, the air, okay, which occupies already, the below the visceral pleura, okay, and above the parietal pleura, okay, you will be able to have a bouncing back of the waves, so that what you will be able to see is just a static structure like this, okay, what we call as a barcode sign or a stratosphere sign. Okay, so this is going to be handy or going to be seen in the M mode or motion mode, because you need the lung, okay, to be able to move so that you'll be able to interrogate whether there is pneumothorax or not. But of course, using the B mode or the brightness mode, okay, two-dimensional, you'll be able to also interrogate it by having no lung sliding, which you will learn later. So the normal lung surface you have here is a air in between, air, and then of course bouncing off, so that what you will be able to see is this grainy structure, sand, on M mode, and on B mode, what you'll be able to see is lung sliding. And there is air fluid, okay? All right. Now, interstitial syndrome, you have intervening more fluid, intervening the air. So what you will be able to see is this air fluid interaction. Later on, you will see as B lines. Now, alveolar consolidation, okay, from the pleural line, what you are able to see are some areas or pockets of solid, parenchymal, which have already lost the air, in between. Okay, so what you'll be able to see is this one on ultrasound, okay, consolidation, like the liver. Now, next is pleural effusion. So it's anechoic area. So more of the fluid has occupied that area in between or below the pleural line. And so what you'll see is a pleural line, okay, structures above the pleural line, which is anechoic. And of course, when you do ultrasound using the diaphragm as your landmark, okay, while the patient is in a supine position, okay, and using a curvilinear probe, then you'll be able to see another anechoic area. Okay, so just a brief explanation on why these are the things that we see on ultrasound. Now, so first is lung sliding. So we position the patient in a supine position, and what we use is a 12L or a linear probe. But in this case, what I have is a handheld ultrasound, for which case you just have a preset of an abdominal or even a linear, so that you'll be able to actually linear, no, for this case, because we're dealing with a superficial structure, lung sliding. So we also will be able to see back sign and the lung sliding on inspiration and expiration. Okay, so this is the curvilinear probe. This is the linear probe. The linear probe will be able to visualize superficial structures, so it is more definite or defined, but you are not going to be able to see deeper structures with this. So it has a high frequency probe. Now, if you wanted to see deeper structures, the curvilinear, and this is what we usually recommend for pleural effusion, okay? And in patients for whom you are also suspecting some pulmonary edema, the curvilinear probe is going to be used for visualizing the lines. Okay, so it is a low frequency probe, 2 to 5 hertz, meaning that the patient has lower or deeper structures that you could visualize at the same time, but the structures will be less defined, no? Unlike the linear probe, right? So for this particular lung sliding, what we will be using is the linear probe, high frequency probe, okay? So these are the scanning lines. You can see that it could be anterior to the chest, posterior to the chest, and at the side, no? Of course, this will be as your patient is in a supine position, but of course, you could also scan them using when they are seated. No problem. You can see here that the patient or the scanner is using a cardiac probe. The cardiac probe can be used for scanning as well, especially for effusion. No? Okay. So the transducer indicator is oriented cephalad. Okay. So there is an indicator here, okay, on the probe. Okay, and make sure that this is always cephalad or it's on the right side of the patient, okay, when you use it, because if not, the structures will be inverted, okay? So first order of your learning now is the indicator, transducer indicator is oriented cephalad. How will they be able to know that that is the transducer indicator? Because sometimes we have this, for example, the indicator is here, okay, but sometimes there is another ridge here, okay. What you do is just make sure that you have some gel. Okay, I don't have a gel, I only have aloe here, okay. And then put in the gel, and then when you tap on it, there will be a wiggling area there, okay, which you will see on your screen. And it should be seen on the indicator, near the indicator. I will show you later. All right, so this is the indicator on the screen. Okay, so if you tap that part of the indicator where you think that it is the indicator, there should be some movement on this side, okay? So the green dot is the orientation marker. For most of the probes that we have, it's always on the right, or on the right of the patient, yeah, or on the left of your screen. But if you will be using the cardiac probe, it's on the other side. But never mind, no, don't think about that. Suffice to say, what we are going to be seeing mostly is the green dot is the orientation marker, and it's always on the left of your screen. Okay, so looking at this one, we just orient ourselves that if we scan, okay, what we will see on the anterior part or superior portion is the chest wall. We have a pleural line, which is a hyperechoic area. And in between, or that is in between one rib and another rib. The rib is usually like black, okay? So also kind of anechoic, but it is not as anechoic as the fluid, okay? So, and there will be some rib shadows here because of the bouncing off of the you will not be able to see any other structures, no, because of the solid ribs. Now, from the pleural line, you also have another line like this, which is the same as the pleural line, copying it. It is a reverberation artifact like the A lines. Okay, so for example, this is the subcutaneous fat. You have coinciding colored structure on the right, and the muscular tissue here. Okay, you have this rib, another rib, intercostal muscle. So you now see that the rib is not as anechoic, no? There are some other echoes in between, no? But you can see it relative to the intercostal muscle, it is much blacker, okay? And you have here the hyperechoic area, which is the pleural line and the pleura, and beyond that is the lung, all right? Okay, so what is the bat sign? So just imagine this one, no? It's like the bat wing, okay, and this is the middle body of the bat, okay? So it's one rib and another rib and the intercostal area. Okay, so it is a basic landmark in lung ultrasonography, so probably just to make life, you know, more colorful or, okay, happier with the bat sign. All right, so now let's look at the ribs. Okay, so this is the ribs and another rib, okay, and the pleural line is in here. Oh, sorry. So this is the pleural line here, okay. Okay, so the lung sliding, I have actually a education, no, but I'm afraid to click this and I might get lost, no, so I prepared another picture for this one. So the butterfly network is a handheld ultrasound, which could probably give you some education as well. So there are some resources there as you tinker on with your gadget, no. So what I will be able to see is like this one, no. So there is an education source for evaluation, no, of pneumothorax, for example. There is a video there, and you can see here that the orientation of the patient is in a supine position, and we place the indicator at the superior or above or cephalad, and then we scan from one intercostal space down, no? So we try to scan everything, right? And then not only the right, but of course on the left, you know that the limitation on the left is that the heart is mostly there, no? So you'll be able to have some visualization of the heart more than the lungs. But of course, you can still visualize more of the anterior or superior portion of the lungs as well. So in total, you can see that there's lung sliding here, okay, and then some reverberation artifact from the lung sliding from the pleural line, some A lines, okay, and this is the rib shadow. So for lung sliding, you have, it is the interaction of the parietal pleura and the visceral pleura, all right? And since you are, what's this, inhaling and exhaling, no, so there will be some movement there. So you can see the visceral pleura sliding against the parietal pleura as the patient breathes. Okay, so here, there is a pleural line here, okay? So this is the pleural line, this is the rib shadow, but you can see even here, from the rib shadow, there is still the pleural line. So when you see this, it's normal, meaning that there is lung sliding, okay? Lung sliding, okay? Of course, there are some comet artifacts, no, comet tail as well. Okay, those shimmering, small, shimmering undulations, no, from the pleural line. But this one will suffice to say that there is pleural line, there is lung sliding. Okay, I hope you got this. So in lung sliding, all right, you will be able to see A lines, B lines also from the lung sliding, A lines, okay. B lines are not usually seen, okay. There are less than 2 as a normal value, but if you have more than 2, there is pathology already. Comet tails, if there's undulations that I showed you from the pleural line. And of course, you have the bat sign from the rib shadow, right? And of course, the M mode later on, okay? So pleural line, all right? And then from the pleural line, there are reverberation artifacts like this one. These are the A lines. These are normal. So it just means that there is air, okay? There are no intervening fluid. There are no intervening pneumothorax or pleural problems, no? So this will just tell you that there's an artifact from the pleural line. It is copying the pleural line. And most of this one is the parenchyma, all right? So it's a repetition of the pleural line. These are horizontal hyperechoic lines and parallel to the pleural line, which are reverberation of the pleural surface from the transducer. All right. So when there is no A lines, it has replaced, something has replaced the lung, okay? Or something has changed in the lung, which has replaced the air with substances. It could be blood, it could be edema or interstitial alveolar edema, infection, contusion, or tumor. So you can just imagine that if these are present, then, okay, the interveat or the pleural line copying or the A lines copying the pleural line will not be seen. Okay, so you have to be worried if there are no A lines. Okay, so what are B lines? So now we have A lines are horizontal, B lines are vertical. Okay, and you have to have the preset of the depth at 16. Okay, so you'll be able to adjust it using your knobs. Okay. All right, so you can see here at least 3 B lines. So these are hyperechoic, so color white, vertical lines, right? So I told you if it's more than 2, it is not normal. So this one probably has some form of edema, okay, or interstitial edema or alveolar edema, right? Okay, so sound and of the lung water. So for this is normal, right? Mild edema, just 1 or 2, okay, moderate, confluent B lines, all right, and then of course severe, right? You can see that. Actually, we see a lot of this one in COVID patients, no? All right, so a lot of the B lines are being seen on ultrasound. So clinical correlation is very important. Okay, so here, you can see interstitial edema with 7 millimeter spacing. Okay, so more far apart, but in alveolar edema, it is more or less, they are closer together and sometimes confluent already. So there is 3 millimeter spacing, which will denote alveolar edema. Okay, so this is what you usually see, no, on the right portion in COVID right now. But previously, that is only probably being seen in interstitial or alveolar edema, okay? Right. So in the context of the period that you are scanning, no? So in 2020, no? So a lot of the differential diagnosis for ultrasound have changed, okay? Now looking at this one is the lung sliding, so just to review, okay? So you identify the ribs, in the posterior shadowing, all right? I go back to that one. This is the lung sliding area. These are the comet tail artifacts, no? Just undulations, which are also hyperechoic, but short only, okay? Unlike the B lines, which are going up to a depth of 16 at least, okay? So this one's comet tails are not to be confused with B lines. Now, the comet tail artifacts are hyperechoic and arise from the pleural interface. Okay, so if you ask me what are these are all the subcutaneous tissue, muscle above, no, the lungs. All right. So here you have the A lines, no, remember that, okay? But what if there is an interplay of these static areas, no, of the stratosphere sign, like this one. So if you have a linear probe, no, you place it there. This is the lung sliding, and this is one rib and the other rib. Using the M mode, you'll be able to see this very beautiful picture of the seashore sign. everything which is static above the pleural line, okay, we'll show to you as a barcode, no, or a linear structures. But below the pleural line, since this is a patient who is normal, no, there is the production or the appearance of parang shore, no, right, or sand, okay, because of the motion, no. So there is still the beautiful interaction of the visceral and the parietal pleura, which is in motion. So there is no air, okay, intervening the visceral and the parietal pleura, which is seen in pneumothorax, which I will show you later. Here, no? So for example, we transect that area, which is this is the pleural line, and there is no lung sliding there. What you will see in M mode is all barcode. This is the pleural line, but beyond the pleural line is still static. There is no movement. Okay, so this is indicative of the barcode sign, stratosphere sign, which is clinically significant as pneumothorax. All right, so here, just to reiterate, the rib shadow, this is the pleural line, and these are the comet tail, and that is the lung sliding. Okay, so this is not the lines, kasi the depth is just shallow, right? Okay. I hope you got that. Now, what about pneumothorax, no? So rib shadow, right? Ribs, this is the pleural line. There is no lung sliding. Can you see that? No lung sliding. So that is pneumothorax. Okay. There is no even comet tail artifact. Kasi nga, the comet tail artifact will arise from the lung sliding. There is none here. Now, which one is a positive pneumothorax? Okay, so you have here, everything is barcode, no? That's positive for pneumothorax. This one is with the sand. So there is still movement there of the visceral and the parietal pleura. There is no air in between the visceral and the parietal pleura. Right, so a next indication for pleural for ultrasound is pleural effusion. So we can identify fluid, okay, by visualizing the diaphragm movement on inspiration, expiration. So you ask the patient to be in a supine position, and what we will use is a low frequency or curvilinear probe. And the mode is D mode, and we try to scan, okay, from the 5th to the 8th on the anterior axillary line on the right side and the mid-posterior axillary line on the left side. We use the spleen on the left and the liver on the right as an acoustic window so that we will be able to visualize that diaphragm and if there is some fluid, anechoic area, and we angle the probe toward the spine. So this could have been a easier task, no, when we have it as hands-on, no. So after all, ultrasound is a hands-on learning, no? So you have to learn it through hands-on. Anyway, so what we will be able to see is an anechoic area above the diaphragm if there is effusion, because when the patient is in the supine position, that is where most of the fluid will go. So if there is even a little bit of fluid, you'll be able to see it in this position. Okay, so this is a reiteration of what you will do, okay? So the probe is a curvilinear probe because you'll be able to see more deeper structures using this. So 2 to 5 hertz, okay? Now how to scan? So 5th to the 8th on the left in the mid-posterior axillary line, and on the right, it's also around 5th to the 8th, but it's at the anterior axillary line. And we have to angulate it towards the spine. Okay, so what you will be able to see is, for example, this is the hemidiaphragm, okay? This is the liver, and supposed to be, you have the liver, okay, since it is a solid structure, you have to see it on the other side as well, where the lung is. But here, what you see is there is some fluid because there's an anechoic area here, and this is the lung which is collapsed, okay? So above the diaphragm is where the lung is, okay? So if there is an anechoic area above it, then there is fluid. Okay, so this is what I had in one of our workshops in UST in 2014. No? So we had a patient whom we scanned, okay? So this is the liver, right? This is the diaphragm, and there is some fluid lung, no? So just a little bit. These are just intervening ribs, no? So be careful about interpreting this one as a very large fluid, no? But this is just small fluid here, okay? So again, anechoic area is pleural effusion. Okay, I'll show you another scan. This one is bigger, larger amount of fluid. Okay, another patient whom we saw in 2014 in one of our workshops. Okay, so here is a collapsed lung, and the whole of this one is the fluid, no? So that's an anechoic area, okay? Right, so a lot of fluid. Okay, I could not delineate anymore where the diaphragm is, but okay, but it's a lot of fluid here, right? Okay. So next indication for bedside ultrasound is to interrogate whether the patient has pulmonary embolism or DVT. So more or less what will be easier to do is a DVT screen. Okay, so what we use is a patient in a supine or a sitting position, and ultrasound probe using a high frequency or linear probe, because you are going to see more superficial structures in the veins, no? Even if they are deep veins, okay? And then of course, B mode, and then we scan the femoral area at the inguinal area on the right or on the left, okay? And we have to visualize the Mickey Mouse sign. I will show you that one. And we will compress, no? So if the vessel, the vein is not compressible, then there is a problem. If there's an is a hyperechoic area in between, there is a thrombus. Okay, so this is the Mickey Mouse sign. It's composed of the common femoral artery, the common femoral vein, and the greater saphenous vein. So if you see this one, you're good to go to be able to visualize the femoral vein, which is the most important one for interrogating for DVT. So if we try to compress that, and if it's compressible, then there is no DVT. If it's non-compressible, there is DVT. Okay, and of course, you'll be able to see also if there is thrombus. So if there is thrombus, there will be an area of white in between, okay? And of course, we may also visualize it longitudinally and also use the image or color flow. Okay. So what about popliteal? So you also will be able to see the popliteal area or popliteal vein, which is also significant for DVT, which is proximal, no? So visualize the popliteal vein and artery. You just lightly scan using the or at the area of the popliteal crease, and the patient may be in a supine or sitting position, okay? But make sure that the knees are bent, okay? All right, so popliteal area, the popliteal vein is above the popliteal artery. So that's the orientation. And the indicator of the probe should always be on the right side of the patient. Okay, so here we see, okay, popliteal vein above the popliteal artery. Okay, so in pulmonary embolism diagnosis, you'll be able to see it in the lungs. So if you're able to do the DVT screen, okay, compressible or non-compressible veins, no? In the heart, you'll be able to see some right ventricular and interventricular septal abnormalities. Okay, just to show you that you can see or you can use ultrasound, no, to be able to define whether the patient may have pulmonary embolism by surmising or having a conclusion from a DVT. Okay, so in 2020, everything has changed, no, because we have a diagnosis of COVID, no, in our midst. So for example, this patient has this X-ray and another X-ray 10 days apart, right? And we were able to obtain an ultrasound, bedside ultrasound for this patient because of these findings, no? So I told you I will be discussing as well COVID, no? All right, so there are areas of consolidation. Now remember that in areas of consolidation, no? So there are some fluid intervening with air, all right, and intervening with some parenchymal problems, no? It's at the right hemithorax. Now, what about here? So looking again at this particular radiograph, correlating it with the ultrasound, you see there are some A lines. No, these are normal. Okay, so a lot of the A lines are seen on the right side. You can see some aerated areas on the X-ray. So correlating it that one to these particular ultrasound findings. Now looking at on the other side, I'm asking whether there is some effusion. I see some obscuration of the right side, so I ask, is there effusion? No, because as you can see here, this is the diaphragm, this is the liver, right? Above the diaphragm, there is no anechoic area. Okay, so just like that, I have answered my question already. Now looking at this one, okay, this is at the left side. Okay, a lot of B lines. You can see that one, huh? Remember, in more confluent, it's in this time of pandemic, it's going to be COVID, no? But of course, in the setting of probably edema, it could be pulmonary edema as well. Of course, the left side also has some consolidation. All right. Okay, I have some more, but this is a 44-year-old female with COVID, no symptoms. Okay, right here. So these are what you see. Just answer in the chat box if you want. So are these A lines, B lines, both, or diaphragm? Okay. So you have A lines. There are no B lines, no? So these are all A lines. So this is wrong, ha? Dapat A lines lang. There are no B lines. Okay, what about this? Right. So this is at the level of the diaphragm. This is the liver, right? There is what? There are no, okay, no effusion, no? There is no paralysis because the diaphragm is moving. Okay, so there is no anechoic area. So that is just, okay, a normal finding. No pleural effusion. There is no such thing as C lines, no? Maybe we will discover that. Okay, next. Okay. Are these normal? Yes, no? Kasi these are all A lines. There is lung sliding. There are comet tails. These are normal. Okay. Is there an anechoic area above the diaphragm? There are none, no? Okay, wala. Okay. There are many B lines. Wala. But this is a setting at 8, so it should be at least 16 if you wanted to see the B lines, no? So these are just comet tail, okay? So these are normal findings, no? No B lines. Okay, next, 62-year-old male, COVID, ARF, ARDS on ventilator. What do you see? Okay, so this is lung sliding, a lot of B lines, no? Okay, there is pleural line. So these are B lines and pleural line. And lung sliding. So wala siyang pneumothorax, ha? Okay. Oops. All right, next. All right, so again, confluent of B lines. And then this one, right? Again, B lines, no? So depth natin is more than 16 na yun. So these are B lines, but with some A lines, okay? Yan. Okay, so last case, a 42-year-old female, previously well, went to the emergency room because of swollen leg and currently on oral contraceptive pills and has returned from a 14-hour flight. And the left leg is swollen, 42 versus 35 on the right. We are suspecting DVT, and so we interrogated that area. Okay, what can you see? So there is non-compressible, okay, popliteal vein. No? Nagko-compress na yung artery, yung vein hindi. All right, so yes, the patient has DVT because there is non-compressible popliteal vein. Right, so we have learned so far the normal lung ultrasound findings on B mode, M mode, dural line, bat sign, A lines, and comet tail. Can you recall that? Yes. And many B lines will say that there is edema, so that's at least more than 2, okay? And pneumothorax, you have absence of lung sliding on B mode and barcode sign on M mode. Anechoic area above the diaphragm will denote effusion, and non-compressibility of the popliteal or femoral vein is seen in DVT. And we have discussed the potential uses of pulmonary ultrasound on the bedside, highlighted here: edema, salvation, can be pulmonary embolism or DVT, and of course the pleural diseases. And of course, if you wanted to have an in-depth look at the Blue protocol, there is such a thing as a B profile, A profile, or AB profile. And whether you are A profile, then the patient will probably be considering, okay, COPD or embolism or pneumonia. And if it is predominantly B lines, okay, B profile, pulmonary edema. And if it is a combination of both, so for example, in the right lung, it's this, on the left lung, it's this, then there may be some form of pneumonia. Okay, so I hope that we could do this soon. No? This was in the World Congress Ultrasound Medical Education last year, okay, set up of a workshop. And me, 2014, for the World Congress Ultrasound Medical Education, this is Dr. Lichtenstein, the father of ultrasound in pulmonary, the French one. And then, of course, some of my colleagues in the World Congress in 2019. So I hope you got something out of our 30-minute talk. Thank you very much.
Thank you very much, Dr. Visperas, for that very informative lecture. It's nice to be updated po with how we can use ultrasound at bedside to diagnose lung pathologies both for our COVID and non-COVID patients.
Thank
Doctor,
you,
we have one question po from the audience. Would you consider using bedside ultrasounds in far-flung areas po, especially in rural areas po?
Yes, yes, of course. No, so as you can see, I have an ultrasound here. Okay, this is my kit, and everything is here. Okay, and this is the ultrasound itself. You can answer a lot of questions using this ultrasound. No, you'll not be able. If, for example, there is no available X-ray or CT scan, and you have that question in mind. Okay, you just put that probe onto your patient. There is not much of a problem. It is very safe. Okay, as safe as you could use it in a pregnant woman, no, for example. Okay, so but of course, you always have to have a question in mind when you will be able to use it, no. So not just I want to scan everything, no. So you have to be judicious in doing the scan. All right. And for example, your question is, does this patient have an effusion? Remember in our correlation a while ago, in one of the cases, there's a confluence of opacifications on the right side. Is there effusion? Do I need to do something else? So you just, answer that one using the ultrasound.
Okay, thank you very much, Dr. Julie. Doc, there's a follow-up question po. Since napakita niyo po yung ultrasound, how much daw po is your handheld ultrasound? Okay. And are there any trainings po here in the Philippines for point-of-care ultrasound setting?
Yeah. Okay, so in the Philippines, we have had a lot of training already. In the Philippine College of Chest Physicians, we did one in 2000, I think think 14. Okay, but in UST we were the first ones who had the workshop in ultrasound in 2013. No, so that was in one of our postgraduate sessions like this, but it's hands-on. No, so we brought in a foreign speaker from the US. No, so he helped us, of course, but we were all facilitators. No, so we have that. Another one is I think we also do that in our postgraduate courses. Come this March, we have a Philippine College of Chest Physicians postgraduate course for the annual convention, and it is one of the tracks for the annual convention. So it's there. So saan nakakabili? Yeah. Siyempre bonus ko to sa faculty, no. Yeah, I went to the World Congress last year and they have it, but we could not buy because we are from the Philippines. No, but some of my colleagues in Lung Center were able to buy. No, so what you have to do is just have someone ship it in the Philippines. No, so this one came in nahuli na ano siya sa pandemic. No? So my uncle was supposed to go in, but he just shipped it in to me via, I think, LBC. But I bought it myself, using the online thing.
Okay. So thank you, Dr. Julie. Dr. Julie, I think Dr. Lansona has a comment po.
Hello.
Yes, Dr.
Julie.
Lansona.
Yes.
Yes, Doc.
I think in comment pa lang, I think you have answered partially the question. Well, it's the portable ultrasound as a point of care has been useful, and in fact, sa Faculty of Medicine sa UST, we have included that in the curriculum. Some comments, you will also read some comments that can it replace the stethoscope, because not only can you listen, but you can also see. So the horizons, there are many opportunities with regards to diagnosis. Let's say point of care, you can diagnose pneumothorax immediately, pleural effusion, you can diagnose hepatomegaly, you can even see the cardiac murmurs already once you were able to appreciate that on PE. So it is a valuable tool, and it could be part of probably sa instruments natin for physical diagnosis, let's say from the stethoscope, from the pen light, probably in portable ultrasound in years to come will be part of the basic physical examination instrument that any clinician can do.
Yes, Dr. Lanzana. Yes, Doctor. Actually, in the UST, we introduced it in the medical education or medical school as early as 2012. So we are the first in the Philippines to educate our students. So we are lucky that we were able to do that, especially now in the pandemic. Most of our trainees and now consultants are using ultrasound.
Thank you very much po, Dr. Lansona and Dr. Julie again for that very, very wonderful lecture. So we would like to present the certificate of appreciation to Dr. Julie Visperas for having lectured in the 17th PEFRI postgraduate course signed by the organizing committee. Okay, so thank you for listening intently to our first two speakers. We shall now have our 15-minute break. Let's grab some coffee to keep us alert and awake, and let's stretch out or wiggle a bit to maintain our blood flow, and we will see you all in 15 minutes. Good morning.
Thank you.
Welcome back, dear colleagues. Let us carry on with our program. Let us call on Dr. Angelica Pearl Reyes and Dr. Maria Cristina Marañon to moderate our next two sessions. Our next speaker graduated from the Divine Word University College of Medicine and took up her residency and fellowship training at Chinese General Hospital and UST Hospital respectively. She is an active consultant at UST Hospital. Ladies and gentlemen, let us welcome the reserved and practical Dr. Mary Ann Dakayan.
Good morning. We start our discussion with a case presentation of a 71-year-old man with hypertension and a history of stable coronary artery disease presents to your office 1 month prior to an elective total hip arthroplasty. So the following are his medications. So our goal is to assess our patient's general medical conditions in order to identify any unrecognized comorbid diseases and optimize the patient's state for the procedure. We begin our evaluations with pre-operative history and physical examinations. In general, the overall risk of surgery is extremely low in healthy individuals. The patient should be asked about his demographic profile, list of medication he is currently taking, including anticoagulant, NSAIDs, steroids, over-the-counter drugs. You should be asked about any of the following conditions: symptoms like chest pain, shortness of breath, chronic cough, lung problem or diseases, family history, past medical condition, any problem with previous surgery due to anesthesia. If he smokes, how many packs per day for how many years? If he drinks alcohol, there's an increased post-operative complication in patients who misuse alcohol on a regular basis. Pregnancy state. We also assess their exercise tolerance. Patients with good functional capacity can climb a flight of stairs without stopping or walk up a hill. Patients with poor functional capacity are unable to walk 4 blocks or climb 2 flights of stairs at a normal pace because of development of chest pain, dyspnea, and excessive fatigue. Pre-operative testing is generally limited to address disease-specific management. If there is no significant change in the clinical conditions of the patient, it is safe to use test results that were performed within the past 4 months. Laboratory testing includes CBC, renal function tests, electrolytes, blood glucose, urinalysis, liver enzyme tests, albumin, ABG, ECG, 2D echo, pulmonary function test, chest radiograph. Many studies show that abnormal chest X-ray may occur frequently, especially in the elderly adults. We may request our patients to bring old film for comparison. Pregnancy test and hemostasis. There are many factors that may influence the risk of perioperative complications. First, we have the surgical stress response and anesthesia. The surgical stress response is activated by the afferent input to the hypothalamus from the surgical site of injury, which results in endocrine, metabolic, and inflammatory responses. Endocrine stress response lead to surge in the hormone productions. Metabolic changes such as catabolisms of carbohydrates, fats, and protein provide increased energy needed for the productions of glucose and acute phase protein. Inflammatory cytokines rise in the postoperative period, and increased activations of platelets contribute to the thrombotic milieu. The magnitude of surgical stress response is proportional to the degree of surgical injury. 2 major classes of anesthesia available: general and neuroaxial. General anesthesia is comprised of trials, analgesia, and muscle relaxations. General anesthesia lead to a multi-system physiologic changes, particularly during the inductions and emergence. The most important effects are hypotension due to vasodilations, myocardial and respiratory depression. Neuroaxial anesthesia, including spinal and epidural technique creates a unique physiologic effect due to blockade of the sympathetic nervous system. The sympathectomy occurs above the sensory level, causes hypotensions and bradycardia. Patients with hypovolemia or preload-dependent cardiac disease, such as aortic stenosis and hypertrophic cardiomyopathy, are at significant risk of complications, including death. Respiratory effects include sense of dyspnea, reduction in expiratory effort, and cough strength. Paralysis of the accessory muscles and diaphragm may occur if a high spinal anesthesia is achieved. And finally, urinary retentions. Awareness of all these important physiologic changes is vital to understanding how best to manage our patients in the perioperative setting. Assessment requires analysis of the surgical urgency, surgery and patient-specific risk, and status of relevant comorbidities. This is one of the classification guidelines of surgical urgency according to the ACC and American Heart Associations. Emergency and urgent status has been shown to increase complications over similar procedures performed electively. For example, unplanned surgery in patients receiving therapeutic anticoagulant. So in urgent cases, procedures must be undertaken regardless of the risk. Surgery-specific risk. So this is a gradations of mortality risk of common non-cardiac surgical procedures. They are separated into higher, intermediate, and lower risk procedures depending on the amount, locations of tissue disruptions, fluid shift, blood loss, and hemodynamic effects, among other variables. So elevated risk procedures include emergent major operations, especially in the elderly, vascular surgery, prolonged surgery with anticipated significant blood loss and fluid shift, and all the major surgical procedures. Lower risk procedures include cataract, dermatologic, and elective endoscopic procedures have fewer hemodynamic shift and smaller surgical stress response. Patient-specific risk. A thorough history and physical examinations are the key component in identifying these risk factors. So Table 1 outlined the commonly used perioperative risk assessment tools categorized by the organ system. So we have the cardiac risk calculators, pulmonary risk calculators, VTE, geriatric risk calculators, hepatic, and so on. These calculators are freely available online to assist us in quantifying an individual risk. The combined medical and surgical risk requires assessment of the following complications in all patients. So first we have the cardiac risk assessment. Given its simplicity and accuracy, the revised cardiac risk index is the favored perioperative cardiac risk assessment. So it relies on the presence and absence of 6 identifiable clinical predictors. Each of these predictors is assigned 1 point, and based on this, the risk of major cardiac events defined as myocardial infarctions, pulmonary embolisms, ventricular fibrillations, and complete heart block can then be predicted. Based on the presence of none, 1, 2, or 3 clinical predictors, the rate of development of one of these 4 major cardiac events is estimated to be 0.5, 1.3, 7, and 11% respectively. So patients with a score of 3 or more are at a very high risk for cardiac complications and may benefit from further non-invasive cardiac testing. This is a stepwise clinical evaluations. So patients with known or risk factors for coronary artery disease needing emergency surgery should undergo clinical risk stratifications and proceed to surgery with monitoring intraoperative and postoperatively. Patients not needing emergency surgery should be assessed for acute coronary syndrome and if identified, should be treated according to the goal-directed medical treatment. For medically stable patients, they should be assessed for risk of MACE based on the combined clinical and surgical risk. So low-risk procedures, no further testing needed, they can proceed to surgery. Elevated risk procedures will proceed to consider their functional capacity. So patients with good functional capacity generally do not need to undergo further non-invasive testing, so they can proceed to surgery. Poor or unknown functional capacity will benefit from pharmacologic stress testing if it will impact on the decision-making or perioperative care. If not, they can proceed to surgery according to the goal-directed medical treatment or alternative strategies. Risk modifications. Prophylactic coronary revascularizations with either bypass or percutaneous coronary interventions are unlikely to improve outcome in patients without significant left main coronary artery disease and is also not recommended for patients with stable CAD. It is recommended, if possible, that elective non-cardiac surgery be delayed 30 days or more following implantations of intracoronary stent because it constitutes the period of time of greatest risk for development of stent thrombosis. For patients who must undergo non-cardiac surgery early after PCI, balloon angioplasty without stent placement is a reasonable alternative because dual antiplatelet therapy is not necessary for such patients. Now, preventive medical therapies, these are the guidelines for beta blockers. So we continue beta blockers in patients undergoing surgery who have been receiving such therapy chronically. Abrupt withdrawal of beta blockers should be avoided because of the associated increased risk of myocardial infarctions and angina. So IV preparations can be substituted to oral preparations in patients who are unable to swallow or absorb the medicines in the perioperative period. Consider initiations of beta blocker therapy perioperatively in very select high-risk patients, so namely those with intermediate or high-risk ischemia or 3 more RCRI risk factors. Ideally far enough in advance to assess safety and tolerability. So we maintain the continuity of lipid-lowering agents and ACE inhibitors. Oral antiplatelet agents are discontinued 5 to 7 days prior to major surgery and restarted as soon as possible post-operatively. Pulmonary risk assessment. Post-operative pulmonary complications may be classified as major and minor complications based on their potential for mortality. So major complications include acute or worsening respiratory failures, which often leads to prolonged mechanical ventilator complications such as pneumonia and increased mortality. Others have cardiovascular complications and worsening of OSA. Minor complications include clinically significant atelectasis, tracheobronchitis, and exacerbations of underlying chronic lung disease. In particular, Canet et al. Identify 7 independent risk factors for post-operative respiratory failures: low preoperative capillary oxygen saturations, at least 1 preoperative respiratory symptoms, history of chronic liver and congestive heart failures, thoracic and upper abdominal surgery, prolonged and emergency surgery. Pre-operative evaluations of the risk for post-operative pulmonary complications, or PPC, must take into account both the patient-related and intraoperative risk factors. So under patient-related, we have COPD. A significant smoking history of equal or more than 20 PAP years should lead clinicians to assume that COPD and other associated pulmonary and cardiac disorder may be an issue even in the presence of a normal spirometry result, as the use of other inhaled tobacco products such as e-cigarettes, cigars, pipes, marijuana, exposure to secondhand smoke, environmental contaminations, toxic medicines like bleomycin and amiodarone may produce effects similar to those of cigarettes. A careful history must be undertaken. Age is a single most powerful predictor among the patient's related risk factors due to increasing number of comorbidities with advancing age. Although many perioperative outcome studies have documented that the physiologic age is more important than the durations of life. Current smoking status. Preoperative smoking is associated with general infections and poor wound healing complications. Smoking increases hemoglobin concentrations and platelet aggregations, which increases the risk of thrombosis. Class 2 pulmonary hypertension. Moderate or severe OSA may have difficult airways causing intubations, oxygenations, and ventilator problems. Nutrition. Obese and malnutrition. Intraoperative risk factors include the surgical sites, major surgeries, particularly upper abdominal surgeries, due to proximity of the incision site to the diaphragm and potential for splinting and shallow breaths after surgery. Laparoscopic technique confirms a less risk for PPC and is recommended in geriatric surgical populations. Durations of surgery of more than 3 hours. General anesthesia have higher incidence of pulmonary infections and prolonged ventilator dependence. Prolonged residual neuromuscular blockers can reduce functional residual capacity, causes loss of respiratory muscle tone, atelectasis, and arterial hypoxemia, and emergency surgery. So our next table is how to reduce perioperative pulmonary complications. Preoperatively, we ask our patient to stop smoking. Cessation of smoking decreases airway secretion, hyperresponsiveness, and improve mucociliary transport. Furthermore, cessation of smoking even closer to the date of surgery decrease carboxyhemoglobin level and improve tissue oxygen utilization. Training in proper lung expansion techniques such as deep breathing exercises, incentive spirometry, and CPAP therapy in elderly and patients unable to perform deep breathing exercises. Consider also pulmonary rehabilitations in patients with severe COPD undergoing elective surgery. Using inhalations bronchodilator and or steroid therapy in asthma and COPD patients at high risk for increased airway resistance due to tracheal intubations. A well-controlled asthma is unlikely to be a risk factor for perioperative pulmonary complications. Evaluate any cough, dyspnea, changes in the quality and quantity of sputum, and treating infections when indicated. Weight reduction in obese patients and providing nutritional supplementations for patients with anorexia and pulmonary cachexia to improve their bodily function. Intraoperatively, limited durations of anesthesia if possible, avoidance of long-acting neuromuscular blocking drugs when indicated. Post-operatively, we continue and optimize inspiratory capacity maneuvers with attention to mobilizations of secretion, ensure early ambulation, encourage our patients to cough, maximize upright posture to minimize aspiration risk, selective use of nasogastric tube for nausea, vomiting, and ill use, adequate pain control, because inadequate relief of pain after high-risk surgeries have a higher incidence of poor functional status and adverse outcome. In general, epidural opioids seems to reduce infections and atelectasis compared to systemic opioids. So all surgical patients undergoing surgery must be assessed for risk of VTE. Factors contributing to high risk include tissue injury, examples, indwelling central venous catheter insertion, surgery depending on the durations and location, cancer, obesity, trauma, immobilizations, and so on. So these tables are the list of thromboprophylaxis among hospitalized patients. So we have major surgery, cancer surgery, including gynecologic and urologic, and major orthopedic surgery. So for pharmacology prophylaxis, we follow the manufacturer's recommendation for dosing. So low molecular weight heparin appears to be effective and is associated with lower risk of bleeding when the first dose is given 12 hours pre-operatively. Intermittent pneumatic compressions and anti-embolic stockings are useful supplement to anticoagulant therapy and in patients at excessive risk of bleeding. Patients with OSA have a higher incidence of perioperative cardiovascular and pulmonary complications and is also associated with multiple comorbidities. And because cardiovascular dysfunction in OSA can be modified by treatment, it is important to identify patients with OSA and begin treatment. The use of standardized questionnaires such as STOP banks provide a simple and useful screening tool to identify surgical patients at high risk for OSA. So possible OSA is based on a score of 3 or more, and the additional presence of bicarbonate equal or more than 28 millimoles per liter improves the specificity for all OSA. So evaluations and management, conducting sleep studies, and initiating treatment before surgery. So we counsel our patients to be adherent to their CPAP therapy during the perioperative period, coordinating a multidisciplinary team, performing preoperative echocardiogram, and extubating patients undergoing general anesthesia while awake unless contraindicated. Full reversal of neuromuscular block must be verified before extubation. And if possible, extubations and recovery should be carried out on a non-supine position. So post-operatively, providing supplemental oxygen and initiating CPAP, carefully considering effects of sedating analgesics on upper airway collapse and depressions of respiratory drive. Patients should be closely monitored with continuous pulse oximetry and end-tidal carbon dioxide. ABG is recommended if with evidence of hypercarbia is found. Now, geriatric populations have a higher rate of medical comorbidities, and management of this condition does not differ from the non-geriatric populations. Issues specific to the geriatric populations include cognitive deficits and delirium, malnutrition, frailty, and falls. Current guidelines recommend screening for cognitive deficits, which is a risk factor for post-operative delirium, and history of falls. Addressing malnutrition and frailty preoperatively with a program, rehabilitations, improved post-operative outcome. So rehabilitation is a form of multidisciplinary team involving respiratory therapies, occupational therapists, sports psychologists, and doctors with the intentions to increase the baseline fitness prior to surgery. Now, in cases of urgent surgery, increased attention to the post-operative rehabilitations and nutrition has been found to be beneficial. Patients' wishes regarding advanced directives should be noted, particularly regarding issues on intraoperative resuscitations. These criteria should be used when prescribing medicines post-operatively. So these criteria are guidelines for healthcare professionals to improve the safety of prescribing medicines in the elder adults. So going back to our patients, a 71-year-old man presents to your office 1 month prior to a total hip arthroplasty. So our patient has a stable coronary artery disease and diabetes on insulin. He has adequate functional capacity. He ambulates without the use of gait aid. Electrocardiogram revealed no worrisome findings. The RCRI score is 1 for diabetes, Gupta risk 1.2%, and the estimated risk of cardiac death is 1.5%. So our recommendation is to continue his metoprolol the evening prior to the evening before surgery. Risk factors for postoperative pulmonary complications include age, COPD, and OSA. His COPD is adequately controlled with tiotropium inhaler, and he's able to walk 1 to 2 miles without respiratory limitations. His lungs are clear on examinations, and he's compliant with his CPAP. So our recommendation is inhalations bronchodilators pre and post-operatively, continuous CPAP therapy in the recovery room and post-operatively. So we continue also intensive spirometry, aspirations precautions, and early mobilization. Our patient is at a high risk for perioperative VTE given the surgical procedure, COPD, and advanced age. He's not at significant increased risk of post-op bleeding. So we would recommend IPC and a man course of low molecular weight as VTE prophylaxis. His mini-COG scores 5, indicating low risk for post-op delirium. Risk factors are type of surgery, age, male, and decreased hearing. We would recommend careful attentions to maintaining day-night activities, early mobilizations, frequent reorientation, and having patients wear his hearing aid post-operatively. Multimodal approach to pain management to minimize the need for opiates is encouraged. Having family presence as much as possible post-operatively can be helpful with reorientation. So this is a mini-COG score which has 2 parts, the item recall plus the clock drawing. His hemoglobin A1C is adequately controlled at 7%. So he should take 50% of his usual glargine dose the night before surgery. And corrective scale insulin can be given as needed until he resumes his usual dietary intake. He is on a stable dose of levothyroxine, and his last TSH was normal 2 months ago. His laboratories were all normal. He will take the following medication the night before surgery and levothyroxine the morning of surgery. So overall, our patient is at acceptable or intermediate risk to proceed with the planned surgical procedures without additional testing. Although several risk calculators are available, a careful history and physical examinations remain the essential elements of pre-operative evaluation. A number of interventions, both before and after surgery, may help to minimize the risk of post-operative complications. However, our focus of care in all patients after surgery is close monitoring and early detections of emerging complications.
Thank you very much po, Dr. Dakayan, for that very detailed lecture. Unfortunately, Dr. Dakayan has some connectivity issues. So she's here with us, but she gets disconnected whenever she turns on her camera or her audio. So if you have any questions, you may type in at the chat box or kindly post it in the chat box, and she will reply to your queries.
Thank you very much again, Dr. Dakayan, for all your efforts po, for joining us here today despite your connectivity issues. And thank you for giving an exemplary lecture po about how we go about pre-operative clearances for non-thoracic surgeries. So we would like to present the certificate of appreciation to Dr. Dakayan for having lectured in the 17th PEFRI postgraduate course signed by the organizing committee.
So our last speaker graduated from the Pamantasan ng Lungsod ng Maynila and had their residency training at the MPI Medical Center, Muntinlupa. She eventually completed her fellowship training at UST Hospital.
Being the enterprising person that she is, she took up pharmaceutical medicine and management at the Ateneo Graduate School of Business and is currently a diplomate of the Philippine College of Pharmaceutical Medicine, befitting her role as the head of the Medical Product Information and Pharmacovigilance Department of Unilab. She is an active medical staff at UST and Gat Andres Bonifacio Medical Center. It is an honor to present our consultant with a big heart, Dr. Maria Ronila Santos.
Thank you, Tina, for that kind introduction. Let me just share my screen. Can you hear me clearly?
Yes po, Dr. Loud and clear po.
Thank you. So good morning, everyone. I hope you are still awake. I'm the fourth lecturer for today. My task is to give you a brief on how to approach patients with pre-existing medical, specifically pulmonary conditions, and assess their fitness to fly. So this topic will present an overview of issues for clinicians to consider when evaluating risks posed by commercial air travel. Of course, if you're traveling alone, you have your own plane, this will not apply to you. So this is for commercial air travel only. So this will be our route map.
Doktora, sorry po. We cannot see your slides po.
Ay, sorry. Wait. Ina, can you see it now?
Hindi pa po, Doktora.
It says here that one should stop screen sharing.
Ayan po, Doktora. Maybe you could try again po. Allowed na po yung share screen. Okay po, Doktora.
Okay na?
Opo.
Okay, are we on slide mode na?
Yes po, Doktora. Thank you.
Okay, so this will be a route map. I will start with the background, physiologic effects of high altitude, and then how we assess our patients pre-flight. In case in-flight medical events occur, how do we approach this? And finally, I will touch a bit on air travel during the time of the pandemic. So this will be our flight plan. Clinicians are often asked to make recommendations to patients about travel safety because air travel exposes people to different factors that could have an impact on their health status. There is also limited availability or absence of medical care in the event of medical emergencies. Hence, we need to prepare. We need a flight plan. Even pilots need a flight plan. So doctors will also need a flight plan. So first, we will examine the physiologic effects of high altitude and air travel. The air pressure in an airplane cabin falls with increasing altitude, resulting in a decrease in oxygen or hypoxemia. This is more evident in elderly passengers and those with compromising medical conditions. Now, before a patient flies, persons with significantly compromising pulmonary disease require advanced planning for travel, including risk assessment, basic planning strategies, and appropriate advice. And finally, should there be instances when our assistance is required for in-flight medical events, we should be able to respond and to do and know what to do in cases of emergency. So, let's start with the background. More than 3.9 billion passengers travel each year. I guess this is 2019 data because most of us only traveled from the living room to the kitchen in 2020. Healthy passengers usually tolerate air travel well, but the aircraft cabin environment can challenge those with pre-existing significant pulmonary disease. One study reports that over a 3-year period, there were about 12,000 in-flight medical emergency calls made by airlines to medical communication centers. So this represents around one medical emergency for every 600 flights. Approximately 12% of in-flight medical emergencies are due to respiratory illness, which is the third most frequent cause of diversions due to medical emergencies. The development of respiratory symptoms during flight after air travel is only Second, to a possible stroke as far as increased risk of hospitalization is concerned. The all-cause mortality is approximately 0.3% of in-flight emergencies, or about 1 in 3 to 10 million travelers. This is what happens at high altitude. I will imitate Dr. Tim and say that on the x-axis, you have the level of altitude, okay? And on the y-axis, you have the atmospheric pressure. Altitude is inversely proportional to atmospheric pressure, so that the higher you ascend, the atmospheric pressure becomes lower. But why is this important to us physiologically? Okay. So this is because a fall in the ambient pressure or atmospheric pressure also leads to a fall in the partial pressure of oxygen in the inspired air. The relationship between the partial pressure of oxygen and atmospheric pressure is demonstrated in this equation. PiO2 equals FiO2 multiplied by the difference between the atmospheric pressure and the water vapor pressure, where FiO2 is the fraction of inspired oxygen. This is 0.21 in atmospheric air. PATM is the atmospheric pressure, which is 760 millimeters of mercury at sea level. And the water vapor pressure is 47 millimeters of mercury at 37 degrees centigrade. Okay, but the effects of high altitude is more evident with unpressurized ascent, like mountain climbing. However, the aircraft cabin is pressurized. Therefore, if it is pressurized, what is the risk of hypoxemia in a pressurized aircraft cabin? Pressurization of cabins on commercial airliners limits the decrease in air pressure, allowing the airplane or jet to cruise at altitudes of up to about 40,000 feet without inducing extreme hypobaric stress among passengers. Regulatory agencies like the FAA require that airliner cabins be pressurized to simulate an altitude of 5,000 to 8,000 feet or less than 2,500 meters, and allow only brief diversions to a cabin altitude of 10,000 feet for safety, like for example, to avoid adverse weather conditions. Remember, when we have the safety instructions when we board the plane or before flying, there is a safety statement. This cabin is pressurized. Should there be a fall in cabin pressure, oxygen mask will fall from compartments above you. This is because if there is a decrease in the cabin pressure, the partial pressure of oxygen in the inspired air will decrease, and it will increase the risk of hypoxemia. The cabin altitude pressure is maintained at approximately 5,000 to 8,000 feet with a cabin pressurization of about 520 to 570 millimeters of mercury. So let's compare now what happens at sea level, where we are right now, and at cabin altitude. So this is a comparison of the inspired pressure of oxygen at sea level and at cabin altitude. At sea level, the partial pressure of oxygen at inspired air is around 150 using the previous equation because the atmospheric pressure is 760. Okay. At cabin altitude, at elevation of 2,438 meters, the atmospheric pressure is around 564. Therefore, the PiO2 decreases to around 109. This is equivalent to around 15% FiO2 at sea level. Okay, so 21%, 15% at cabin altitude. Okay. If you're a normal individual, you typically experience a decrease in the PaO2 from above 95 millimeters of mercury to between 53 and 75 millimeters of mercury at cabin altitude. Okay? But because the change in the PaO2 occurs in the flatter portion of the oxyhemoglobin dissociation curve, that is the red arrow, the decrease in O2 saturation is only 3 to 4% and is not associated with any symptoms. However, if you have compromised pulmonary condition, you have, let's say you have COPD, your PaO2 is below 95 at sea level. Okay, at cabin altitude, the change in the PaO2 will be on the steeper portion of the oxyhemoglobin dissociation curve. So it will more likely be accompanied by a more steep decrease in the PaO2 and will be most likely accompanied by symptoms ranging from marked cognitive dysfunction, dyspnea, chest pain, or confusion. Okay. So the following recommendations were taken from the BTS recommendation, which was published in 2011. There's an update in the website that they will be coming up with an updated recommendations next year on managing patients or passengers with stable. Take note, this is stable respiratory disease, planning air travel. The main aims of these recommendations were to, of course, enhance passenger safety, particularly those with lung disease traveling on commercial air flights, and reduce respiratory complications. And the second one is for us healthcare practitioners to understand that patients with respiratory disease may require clinical assessment and advice prior to air travel. So for the patients with the following disease conditions, they should be assessed with a thorough history and physical examination at the minimum. If we have any doubts about the patient's fitness to fly, and if there are comorbidities affecting illness, like for example, cardiovascular disease, or the patient is on immunosuppressant therapy, assessment is advised. In general, the patient should be stable and have recovered from any recent exacerbation prior to travel. Okay. The following are pulmonary contraindications to commercial air travel. So if your patient still has infectious tuberculosis, or the patient has pneumothorax, or major hemoptysis, and if the oxygen requirement at sea level exceeds 4 liters per minute. Now we go now to disease-specific recommendations. Let's start with COPD. The physician's advice to COPD patients who intend to fly depends largely on the type, reversibility, and functional severity of the disease, the evaluation of altitude tolerance, and of course, safety of the patient, the anticipated altitude and duration of the flight. Additionally, there is also a need to assess if the patient will require in-flight supplemental oxygen. This is because in patients with significant lung function impairment, even a small degree of hypoxia may lead to problems which may be correctable by therapeutic oxygen. The main challenge for us is to identify those who will benefit from it. Now, in evaluating a patient with COPD, consider any previous flight experience, the flight duration. Usually, if the flight is more than 4 hours, it is considered significant, and if relevant, the last exacerbation of the patient. So how do we assess who will benefit from in-flight oxygen? So this can best be done not only by pre-flight history, physical examination, routine laboratory tests, but by pulmonary function and blood gas determinations. So if the patient has abnormal lung function, it indicates that the patient has poor lung reserve. And further assessment is should be considered. Okay? What is very important is the measurement of arterial blood gas. It is the single most helpful test because PaO2 at sea level is considered the best predictor of altitude PaO2 and tolerance. So if the patient has a stable ground level PaO2 greater than 70 millimeters of mercury, this is considered adequate in most cases. However, a lesser PaO2 may be effectively managed with in-flight oxygen. Now, if the patient has elevated PCO2, it indicates that the patient has poor pulmonary reserve, has increased risk at high altitude, even with oxygen therapy. Okay. For patients who do not require supplemental oxygen at rest, measurement of the pulse oximetry may suffice. This is when the patient is resting and breathing room air. So the values here are assumes that the patient is resting. This is at sea level. So if the patient has a resting pulse oximetry of more than 95%, it is unlikely that their PaO2 will decrease below 55 millimeters of mercury at cruising altitude. So in-flight oxygen is generally not needed. However, there was a prospective study done of patients with a variety of lung diseases. They found that in 23% of patients with normal resting SpO2 at sea level, they also experienced a decrease in PaO2 to below 50 while breathing a hypoxic gas mixture, which simulated aircraft cabin altitude. So while none of these patients develop significant respiratory distress in flight, we have a low threshold for proceeding for additional assessment when patients have underlying disease. So if the patient has subjective complaints at sea level, even if the O2 sat is more than 95%, we have to do additional testing. Okay. If the patient's O2 sat at resting O2 sat at sea level is between 92 to 95%, we assess for risk factors. I will mention the risk factors in the next slide. If the SAT is less than 92, these patients are candidates for in-flight oxygen. We can also use a 6-minute walk test to determine if the patients will require in-flight supplemental O2. So if the patient has a resting O2 sat of 92 to 95% and an O2 sat of less than 84% on a 6-minute walk test, these patients are prescribed supplemental oxygen for air travel without further testing. If the patient has a resting SpO2 of 92 to 95% and 6-minute walk test O2 sat of more than 84%, these patients are referred for further testing, such as the hypoxic altitude simulation testing. But if the patients have O2 sat of 95% or more, a 6-minute walk test of less than 84%, these patients are also referred for HAST. So again, these are the risk factors to assess if patients will require additional testing. So just read through that. So a more sophisticated test to determine the suitability for flight is the hypoxia altitude simulation test, or HAST, or sometimes it's called HCT. This is done by determining the patient's PaO2 while breathing mixed gases, simulating aircraft cabin environment. This is 85% nitrogen and 15% oxygen. If the PaO2 is low, medical oxygen must be considered. So this oxygen concentration is chosen as it simulates the oxygen concentration that an individual would need, would breathe at an in-flight cabin of a cabin altitude of about 8,000 feet. So how do they do the test? They do a baseline, and then they give the gas mixture via a tight-fitting mask for 20 minutes. During that time, the patient is monitored for any chest pain, signs of respiratory distress, pulse oximetry is also measured. And then after 20 minutes, the O2 sat and the PaO2 is measured again by a PaO2. If the PaO2 is more than 50 and the SpO2 is more than 85 at HAST, in-flight oxygen is not required. However, if it is less than 50 and the SAT is less than 85, in-flight oxygen is required for the patient. Okay, so there is an algorithm that suggests which patients should use in-flight O2. So I got this from Up to Date. Don't worry, I tried to break down this busy slide. So number one, first question to ask, does the patient use supplemental oxygen at baseline? If the answer is yes, assess. The next question is the patient using more than 4 liters per minute at rest? If the requirement of the patient is more than 4 liters per minute at rest, you should advise the patient to avoid air travel. If the answer is no, then you just increase the oxygen by 1 to 2 liters per minute over baseline while in flight. Okay, so if the answer to your first question, does the patient use supplemental oxygen at baseline, is no, let's proceed to the next slide. Okay, your answer is no, then you have to assess the resting SpO2 at sea level. If the SAT, as I've mentioned previously, is less than 92, prescribe in-flight O2 at 2 liters per minute. If it is between 92 to 95%, then you have to do 6-minute walk test. If it is less than 84%, in-flight O2 is required. Okay, if the SAT is more than 95%, then you have to ask for symptoms. Does your patient have dyspnea at baseline or symptoms during previous air travel? If it is yes, then you have to proceed for further testing. Okay, so your SAT is less than 84% during 6-minute walk test. The answer is no. Then you have to do a hypoxia altitude simulation test. Same way, if the patient reports exertional dyspnea and your SpO2 is less than 84 during a 6-minute walk test, then you have to do a HAST. Okay? If your patient does not report exertional dyspnea and you do not have symptoms, the patient did not have symptoms during previous air travel, supplemental oxygen is not needed. Okay? So, can you do a HAST? Does your institution have a HAST? If no, empirically prescribe in-flight oxygen at 2 liters per minute. Now, while doing the HAST, if the SAT is less than 85 and PaO2 is less than 50, empirically prescribe in-flight oxygen at 2 liters per minute or titrate it during the HAST to flow that achieves a SAT of more than 90% and prescribe that flow for air travel. Okay? So, You have decided now that your patient requires oxygen. You will have to arrange, even oxygen-dependent patients can fly with adequate precautions. However, you have to arrange some logistics. So some patients are allowed to bring their own cylinders on board if agreed with the airline. You might need to fill up Mediform or the medical form of an airline company. This is usually completed by the patient and the patient's physician with details of the patient's condition and oxygen requirements. This is reviewed further by the airline's medical officer or external advisors who will then evaluate the patient's need. So this is an example of a Mediform. This is from the Philippine Airlines. So you need to answer if the patient will require oxygen on board, how many minutes, is it continuous, etc. Okay. Additional logistics, will the patient require humidification equipment? Usually the oxygen is prescribed between 2 to 4 liters per minute, should be given by nasal cannula. If your patient is very frail, sometimes airlines now use breath-activated systems. This may be difficult for some patients to use. So you have to ask the airline about it and agree to an alternative. Some also allow the use of oxygen concentrators. So in the US, these are some brands that can be allowed on board. Now, another important issue for patients traveling is the need for oxygen on ground. Remember that we are only arranging in-flight oxygen therapy, but some patients have to change flights, so they need oxygen on the ground. For patients with such requirements, direct flight, of course, is preferable because there is no need to arrange ground oxygen. However, if your patient has connecting flights, you need to make separate arrangements for oxygen while on the ground during stopovers. Let's say, for example, your patient is going to Europe or to the United Kingdom, book PAL because they have a direct flight to London. Don't book KLM because it has a stopover in Taiwan. You may need to arrange for oxygen requirements at the airport in Taiwan. Okay, now let's go to asthma. Patients with severe unstable asthma, those who have been hospitalized, within 6 weeks should not fly until they are symptom-free on a stable asthma regimen. So if you have asthma, you are flying, you have to carry your reliever medication. This may be your SABA, or this may be your formoterol ICS inhaler. And if you have severe asthma, you have to carry a course of oral steroids. If you have cystic fibrosis, bronchiectasis, other comparable lung diseases, you should be provided with appropriate antibiotics, secretion clearing medications to be used before and during a flight. Also important, you have to the patient has to stay well hydrated because the cabin air is very dry. Another problem for this patient may be a thickening of the mucus. Also, if in-flight oxygen is indicated, the patient should be provided in-flight supplemental oxygen. Okay, how about pneumothorax? So, I've discussed previously the effect of decreased atmospheric pressure on the partial pressure of inspired oxygen. But factors that might predispose certain individuals to pneumothorax during air travel include air trapping due to airway obstruction, expansion of the air trapped in non-communicating blebs, bullae, or intrapulmonary cysts. During ascent to altitude, the expansion of the trapped air can lead to rupture and cause pneumothorax or pneumomediastinum. Remember Charles' law, P1, V1, Boyle's law pala, sorry, Dr. Tim. Remember Boyle's law, P1, V1 is equal to P2, V2. So, at high altitude, you have a decrease in the ambient pressure. So that will lead to expansion of volumes contained in plebs, bullae, and intrapulmonary cysts. Okay. So if your patient has an ongoing current pneumothorax, this is an absolute contraindication to travel. Now, if the patient already has a thoracostomy tube in place with a Heimlich valve for decompression, they may be able to tolerate air travel when medically necessary. Okay, so we should follow an individualized approach and consider the likelihood of recurrence and how well our patient will tolerate subsequent pneumothorax. For patients with radiographic resolution of traumatic or spontaneous pneumothorax, air travel is typically postponed for at least 2 weeks, although data for this is limited. In patients with more severe underlying pulmonary conditions, longer delay is recommended because these conditions may predispose to recurrent pneumothorax. Now, what if you are called in flight by an FA and say that, Doc, we have a patient with pneumothorax in flight, and we heard earlier that you are a pulmonologist or you are a doctor. What do you do if you get called? The most important thing to do for a patient who develops signs and symptoms of pneumothorax while in flight is administration of supplemental O2. That's the most important intervention that you should do for the patient. For patients with respiratory distress, emergency, you should advise the captain to have a diversion, emergency landing at the nearest airport to allow prompt evaluation and insertion of a chest tube is needed. Now, if there's no enough time to wait, the patient has tension pneumothorax, and you feel qualified, you can use a makeshift chest tube. This may be life-saving for a patient with a tension pneumothorax. So, are you ready to do this for a patient in flight? So, in case you're interested, can you hear the sound?
No po, Doktora. Maybe because naka-earphones po.
Okay. So again, so there's a kit provided to do a needle thoracostomy for tension pneumothorax. So the first thing, of course, is to clean the area where you will insert the needle. So you have to locate the appropriate landmark. That's the suprasternal notch, sternal angle of Louis. Over that, you have the needle insertion point will be above the third rib, mid-clavicular line. So clean it first, and then insert the needle 90 degrees, 90 degrees on top of the third rib at the mid-clavicular line. So you may hear a swooshing sound. once you insert that, and then remove the needle and connect it to a three-way stopcock and turn it to the off position so that no air enters, flows through the tubing. Okay? So, kaya nyo ba yan gawin? Ako hindi ko kaya. Divert na lang ang flight. Okay? So, let's go to another disorder. If the patient has sleep disordered breathing and the patient intends to sleep during the flight, baka naka-business business class siya, so you should advise the patient that if you are planning to sleep in flight, bring your own device. So another problem, potential problem for patients for long distance travel is deep vein thrombosis. So long distance travel, either by air or land, confers a small risk of venous thromboembolism. So there are commonly associated risk factors and then less commonly associated risk factors. So the most commonly associated risk factors are recent major surgery, prior VTE, malignancy, pregnancy, advanced age, use of estrogen-containing oral contraceptives, obesity, and hereditary thrombophilia. So other less commonly associated risk factors, immobility, like for example, window sitting, the presence of 2 or more risk factors for VTE, and some say females. So, do we require thromboprophylaxis for all patients traveling? So, the answer, it's not necessary for most travelers. So, you have to assess the risk of the patient for travel-associated venous thromboembolism. For example, if the travel would last for about 6 hours in a patient with risk factors for VTE, like me, I'm female, I have risk factors for VTE, I may benefit from simple general measures and graduated compression stockings. The data is insufficient for the administration of routine pharmacologic prophylaxis like low molecular weight heparin, aspirin, or warfarin. So if in travelers without risk factors for VTE, general measures for thromboprophylaxis are typically not recommended but are not harmful. So if the patient or the traveler is already receiving therapeutic anticoagulation, regardless of the indication, no additional measures to prevent VTE are generally needed. So general measures, frequent ambulation, walk every 1 to 2 hours. Although maiinis sa inyo yung katabi nyo, just tell them, I'm preventing VTE because I have several risk factors. So you can do also exercises, frequent flexion, extension of the ankles, or calf muscle stretching or thigh muscle stretching. You can also use graduated compression stockings. So 15 to 30 millimeters of pressure at the ankle may be beneficial in patients considered to be at risk for travel-associated VTE. Now, this is below the ankle or at the ankle. So, pharmacologic prophylaxis, lack of data on safety and efficacy should be individualized depending on the risk category of the patient. Now, we go now to infections. There are certain infections that prohibit travel. So among these are tuberculosis, Ebola, now COVID-19. I don't know if you remember an occasion in 2007 when a man who was living in his home from Atlanta flew to Paris to have his wedding and honeymoon there. So it created a a scenario where the CDC was notified about his whereabouts because they said that this patient was not advised to fly because he had extremely drug-resistant tuberculosis. It turned out later on that the patient only had MDR-TB. But then in the United States, if the patient has ongoing active tuberculosis, infectious, they are not allowed to fly. Okay. This is the concern of everyone right now. I don't know if air travel will ever be the same again with the COVID-19 pandemic. So the following people should not travel by commercial airline. So individuals, if you have symptoms, any symptoms consistent with COVID-19, those who are suspected or who test positive for SARS-CoV-2, regardless of the presence of symptoms, if you have been exposed to COVID within the prior 14 days. And if you are waiting for your test results, delay your flight. This is the advice from the CDC. So, delay if you are sick with fever, cough, or other symptoms of COVID-19. You have recently tested positive for COVID-19 with a viral test. You have had close contact with a patient or with a person with COVID-19 in the past 14 days, or you are waiting for results of your COVID-19 viral testing. That's why for most of our OFWs, they are after they arrive in the country, they are usually tested first in quarantine before they are allowed to join their families. Or if you are flying, once you arrive in the country of your destination, you are also advised to quarantine yourself. Now, I have not discussed everything that is covered by the BTS recommendation in the interest of time, but this is a summary of the potential risks posed by travel across varying health conditions. So you may just read through them. Okay, so the final portion of my talk will be managing in-flight emergencies. Why do we need this? There's a rising number of commercial air travelers, the aging population of travelers, retirees, the elderly travel more because they have more money. And of course, increasing mobility of people with acute and chronic illness. So what predisposes us from getting sick inside the cabin? So I've talked previously about reduced oxygen, the reduced ambient pressure, and potential complications. Okay. Also, the air quality in the cabin is very low. Okay. So it's very dry, usually around 10 to 20% humidity, where the optimal humidity is around 40 to 70%. So low humidity can dry the skin, corneas, air passengers, so it can trigger exacerbations of asthma or COPD. You also have insensible water loss. So sometimes inside the plane, parang dry na dry yung lalamunan mo. No? Low humidity can also contribute to thick mucus in patients with cystic fibrosis, bronchiectasis, or similar conditions. Now, there's also risk for transmission of airborne pathogens. Although commercial aircraft's air conditioning and ventilation system uses HEPA filters, which is able to maintain low bacteria, fungi, and viral counts in the cabin, there are reports of individuals possibly contracting a number of infectious disease through airborne transmission through commercial flights, including TB, influenza, COVID-19. So the risk of infection is greatest on flights longer than 8 hours and among passengers seated within 2 rows of the infected passenger. So take note of your seat number and your row, okay? Just in case that there is a reported infected passenger in your flight. Nevertheless, some reports describe that there's also possible in-flight transmission in COVID-19 to passengers seated very far from the index patient. So how is that possible? It is possible to have occurred before or after the flight when the passengers may be close to each other while on board, while online for boarding, using the bathroom, awaiting security immigration check. So rarely will these infections cause acute problems in flight. However, you need to take note that there is a risk for in-flight transmission of airborne pathogens, especially now in the time of the pandemic. Finally, general environmental factors inside the plane, okay? Turbulence, vibration, it can precipitate motion sickness, falling overhead items can precipitate injuries. So also, traveling long disrupts your circadian rhythm, gives rise to your jet lag, okay? Disrupts your medication schedule, okay? Now, what is the airline protocol for in-flight emergencies? Usually, the cabin crew is notified of a possible medical emergency. The captain is informed of the situation. The crew solicits assistance. Have you been in a flight where there's announcement on the PA that is there a doctor on board? We have a patient with a medical emergency, etc. Okay. The captain also calls for ground-based medical support as needed. So based on the assessment of the passenger's condition, it is the captain who makes the decision whether there will be no change in the flight plan, but request for medical personnel to meet the flight upon arrival is requested, expedited landing at intended destination, or is there a need for diversion to a closer location? So, should you answer the call of need, these kits are available, okay, to those responding to in-flight medical emergencies. This is a standard provided by the International Civil Aviation Organization, which monitors standards and recommended practices for commercial aviation. So there are 3 types of kits available in flight. So you have the first aid kit, FAC, proportional to the number of seats in the aircraft. So 1:100, 1 first aid kit per 100 passengers. So normally the contents of the first aid kit are primarily for wound care. Some countries will carry non-prescription medications. Okay. Now, for longer flights, it is advised that the plane carry an emergency medical kit. Okay, so for flights longer than 2 hours, carrying more than 100 passengers, they carry a medical kit for the use of medical doctors or other qualified medical personnel in treating in-flight medical emergencies. So it contains medications, equipment that is opened only under the responsibility of a qualified healthcare practitioner. And they also have a universal precaution kit, which contains personal protection equipment for crew members and volunteer health professionals who may be exposed to a communicable disease in flight. Okay, so these are some of the medications that are available on board. So there's wide variety of medications that are available, but these are the ones that are commonly seen in the emergency medication kit. Of course, you also have equipments available for use. Now let's go to respiratory complaints. Overall, this accounts for 5 to 15% of in-flight medical emergency. Commonly, this is due to asthma or COPD exacerbation. It causes also around 5 to 15% of diversions. And the most concerning is that it causes the second greatest number of deaths after cardiac events. Triggers include hypoxia, the dry cabin air, medicine non-compliance because of the logistics of the travel. Now, available treatments in flight include oxygen, bronchodilator. Sometimes it's not in the emergency medical kit, but it is with co-passengers who may allow you to borrow their bronchodilator medications. Epinephrine, injectable steroids, oral and endotracheal airways with bag mask ventilation devices. Okay, now let's go to our concern, infectious disease. Infectious disease create difficult challenges for commercial airlines because we have to balance that we have to care for the symptomatic patient while the risk posed to the flight crew and other passengers must also be managed. So new and emerging infectious disease can be spread internationally, like what happened with COVID-19. It's not unusual for travelers to try to return to their home country to disguise their condition if an infectious disease is discovered while they are abroad. So during a flight, contact with passengers who may pose a risk of transmitting serious infection should be restricted to the greatest extent possible as soon as the risk is identified. Let's say, for example, they find that they have a person with fever inside the flight, they have to isolate that patient immediately. This may involve moving surrounding passengers to other seats and using standard precautions such as gloves or masks. Okay, so I've mentioned previously, they carry a universal precaution kit, and then they should follow basic universal precautions. So according to the ICAO, a passenger is more likely to have a communicable disease when they have a fever or a temperature of 38 degrees centigrade or greater associated with any of the following clinical signs and symptoms. So once they reach the country of the destination, the captain has to report this condition to the necessary authorities of the receiving country. So have you ever responded to a medical emergency in flight? So fear of liability has always been cited as a reason for trained medical personnel traveling as passengers from assisting during medical emergencies. So in the US, they don't obligate a physician to render assistance. However, it is widely considered an ethical duty to provide help when possible. So the Aviation Medical Act of 1998 applies when a medical professional volunteers to provide care during a medical emergency. So you are protected against malpractice litigation if the following conditions are met. You are medically qualified to perform the service, you act voluntarily, you act in good faith, you do not engage in gross negligence or willful misconduct, you do not receive monetary compensation. If your seat is upgraded or you receive travel vouchers as an incentive, this do not count as compensation. Okay? So when we say medically qualified individual, it refers to any healthcare professional who is licensed, certified, and otherwise qualified to provide medical care in a state, including physician, nurse practitioner, PA, paramedic, EMT. So non-monetary recognition for such assistance, including mild credits, it upgrades, other gifts, if accepted, can be understood as a token of gratitude from the airline and not a compensation for the services rendered. Now, in the US, they do not penalize you if you don't respond to an emergency. However, in British and Canadian laws, this is similar. But there's a major difference in countries that regulate air travel using civil law. For example, France and Germany, among many countries in the European Union. So for these countries, they impose an obligation on physicians to render aid, and if aid is not provided, the physician can be punished by fine or imprisonment. So moral lesson, pagka nagbabiyahe po kayo, huwag niyo pong sabihin na doktor kayo, especially if you're traveling to Europe, kung ayaw niyong mag-respond sa medical emergency. Okay? So how do you avoid legal complications? Consent, obtain passenger consent when possible, use an interpreter if necessary. Let's say the patient is German or French or Spanish, okay? Ask whether ground-based medical support is available to help you, particularly if the situation falls outside your medical specialty or your skill set. If you assess that this is a serious medical condition, recommend diversion to the closest appropriate airport. But just remember that the captain is not obligated to follow your recommendation. Document everything in writing. Okay? Be cautious, particularly in unfamiliar interventions. So like I said previously, if you're not comfortable doing the needle thoracotomy, don't do it. Do not accept or request financial complication or any medical assistance provided. Okay, this is very important because some of us drink alcohol in flight. So if you have ingested any alcohol or medication that may impair your alertness or judgment, it is best not to care for a sick or injured patient. An intoxicated or impaired medical provider is at risk of being categorized as engaging in gross negligence and willful misconduct. So, finally, the Good Samaritan laws only apply to in-flight medical emergencies. They do not apply to non-emergency medical advice that you may provide. Okay? So, what to do for patients? How do we advise them? Okay. Ask them to make a list of all their medical conditions before they fly. All medication should be in the original label container containing a detailed list of all medications, including doses and allergies. A medical alert bracelet for severe diseases or allergies will be very helpful. And if a patient has a cardiac condition, they should have a copy of their most recent ECG. Now, for physicians, before they fly, if they have compromising medical conditions, evaluate and assess patient, consider specialist evaluation, accomplish the MEDIF if necessary. If you are uncertain about the patient's ability to fly on a commercial airline, they may consider referral to an expert in aerospace medicine or review the Aerospace Medicine Association medical guidelines for air travel. So in summary, I have discussed the effects of high altitude and physiologic changes brought about by air travel. Remember, high altitude, low barometric pressure, low inspired air, high risk for expansion of pneumothoraces. You have risk of hypoxemia among patients with low pulmonary reserve. If the O2 requirement is more than 4 liters at sea level, advise patients to avoid air travel. If the resting O2 sat at sea level is below 92, prescribe in-flight oxygen. For patients with airway diseases, bronchodilators are important to carry on board. For bronchiectasis, CF, and related disorders, hydrate, mucolytics, antibiotics. All patients with chronic lung disease assess need for in-flight supplemental O2. For pneumothorax, when to allow travel, individualize the approach. Pneumothorax in-flight, oxygen, emergency. Are you ready to do a makeshift chest tube? For patients with sleep disordered breathing, bring your own device. For patients with risk for deep vein thrombosis, general measures for precautions for prevention, lack of safety and efficacy data on pharmacologic thromboprophylaxis. For infections, active TB, do not fly. COVID-19, delay flight. And then final portion was management of in-flight emergencies. I'm sorry for taking too much time. I will now turn you over to our moderators for any questions.
Thank you so much po, Dr. Santos, for that very interesting and enlightening presentation.
I agree, Pearl, from physiology to clinical approach and management, as well as legal implications, were all thoroughly explained by Dr. Nini. This is indeed helpful nowadays since our locally stranded individuals are now allowed to fly home.
So, we'll proceed with the Q&A po with Dr. Nini. So, Doc Nini, what do we do with patients in the clinic who have a resting pulse oximeter of less than 95% but refuse to have an ABG done, either due to financial constraints or logistics problem? Can we just automatically prescribe them 2 liters per minute or in-flight oxygenation?
If possible, you can do a 6-minute walk test. And then if the 6-minute walk test drops to less than 84% while doing the test, then you can prescribe in-flight O2 at 2 liters per minute empirically. If, however, the patient's SATs do not drop while doing the 6-minute walk test, then patient most likely will not require in-flight O2. But we have to explain to the patient that there is a risk, particularly if they have symptoms of dyspnea, chest pain, etc. If they don't have any symptoms, okay lang. But if they are symptomatic, it is best to assess them. Like I said previously, low threshold for evaluating patients with compromising pulmonary disease.
Thank you, Dr. Santos, for that answer. I also have another question po, Dr. What about po for our patients with OSA? Kasi you've mentioned it earlier po, no? So should we advise them po to undergo repeat titration studies before flying or maintain lang po yung setup po natin in flight po?
If they will be able to use their devices in flight, I guess they just have to continue, because in OSA naman, what is titrated is the pressure, not necessarily the oxygen. Baka nandiyan si Dr. Moral who can answer more thoroughly, our sleep specialist, calling a friend.
Hindi ako nakabihis, ha? Anyway, mamaya pa yung aking symposium. But anyway, what's important is you have to consider the length of the flight. Sabi nga ni Nini, it was anytime you sleep, it's not just nocturnal sleep, but even naps. And if you have sleep apnea, you really have to use your CPAP. Right now, you have a lot of portable CPAP. So one of the rules, sabi nga ni Nini, is very important. Don't check in your CPAP, no? Dapat yung CPAP mo, ideally carry on. And there's usually a permit that you can do that. And there are a lot of portables. So ideally, you should be able to use it. Because remember, as long as you sleep The good adherence is at least 4 hours. And one of the challenges when you travel is, of course, the alteration in sleep patterns may actually worsen the sleep apnea kasi nagiging irregular. So if you fail to bring your CPAP though, usually there's a residual effect for CPAP by at least mga 7 days. So even if you miss one day, you still have some benefit that is a residual from the previous day. So although that is possible, if you can make use of it, if you have a small one that's allowed to be carried on and used on flight, then you can do that, as mentioned by Nini in her lecture, the excellent lecture.
Okay, thank you po. Thank you very much po, Dr. Anini and Dr. Morel for the answer po. So I think we don't have any other questions po. There are no questions posted in the chat box. So with that, we would like to thank Dr. Anini once again, and we would like to present the certificate of appreciation to Dr. Santos for having lectured in the 17th PEFRI postgraduate course signed by the organizing committee.
Thank you, Tina. See you later at 5.
Thank you po.
Okay.
Thank
So,
you to our participants.
thank you, Doc. So we've just finished our 4 lectures for the second day and are now halfway through our postgraduate course.
Please do not forget to join us in our industry-sponsored symposium later at 5 p.m.
So the link is available at our website, and we will likewise send the link in our Viber groups.
Please don't forget to fill up the feedback form for today's session as well.
The link to the feedback form is already seen at the chat box and sent to the Viber group chat as well.
Okay,
So,
thank you very
thank
much
you.
po. And see you all this afternoon. Good day po.